The world is in the midst of a pandemic, and we are on the front lines. Yet cardiovascular disease is still the #1 killer worldwide and can't be ignored. Welcome to Top 10 Topics in Clinical Cardiology 2020. While COVID-19 has challenged us to take our conference online, course directors Dr. Samin Sharma, Dr. Jagat Narula, and Dr. Annapurna Kinney have created a packed and compelling program. Over the next 2 days, you will be exposed to new and emerging approaches in the diagnosis, management, and treatment of heart disease, including COVID-19, opinions of clinical and academic experts, and ways to improve overall care and prognosis. Following our 2 days together, attendees will comprehend the COVID-19 disease process and outcomes, learn to assess CAD risk factors and imaging, acknowledge recent transcatheter valve therapies, recognize the issues pertaining to antithrombotics post-DES, incorporate the latest advances within interventional cardiology. Attendees who are present for both days will receive CME credit. In addition, the full program will be accessible online post-conference on our website, www.ccclivecases.org, and YouTube channel CCC Live Cases. Thank you for joining us. There is nothing quite like the study of cardiovascular disease to remind us to strive towards an active, healthy lifestyle. And remember, wear a mask, wash your hands, practice social distancing, stay safe, and enjoy the conference.
Okay, good morning. For the second half day of our virtual 10th annual Top 10 Topics in Clinical Cardiology, it is my distinct pleasure with my course co-directors, Dr. Jagat Narula and Dr. Annapurna Kinney, to welcome you. And knowing that physically present, virtually present, an entire conference, 4 hours yesterday, it was a tremendous success with high quality lectures and salient question answers. I hope we'll deliver the same high quality lectures in next 6 recorded talks today. And of course, we would encourage people to ask the questions, very important, and knowing that this course will be archived in the next week or so on our ccclivecases.org Top 10 Topics. Very important because our focus has been to bring everyone. Yesterday, there were a lot of topics and based on the COVID. Today is non-COVID, but clearly various advances in clinical cardiology and interventional cardiology will be shown today. With that note, I'll ask my co-director, Jagat Narula first, and then Dr. Annapurna Kinney to a brief introduction before we start today's proceedings. Jagat?
Thank you, Dr. Sharma. You said it all. Yesterday was an exciting day, and there were 200 registrants plus innumerable number of people online yesterday, and we look forward to similarly an overwhelming response. Also heard a lot from people by the chat box, as also from the text messages, as well as by the emails, that they were really they enjoyed it yesterday, and we believe that we will be able to deliver the same quality today, as there are all the speakers, one better than the other. So enjoy the day, good luck, and we are looking forward to your questions as well as your comments, and what are the things that we need to do more to improve it further and to add to it when we come to you next year. Thank you.
Good morning, everybody. And all I would say is just send us more questions through the chat. We want more questions from you as you're listening to the lecture. What is it that you need to know from us so that you can use this for your clinical practice? Like Dr. Sharma mentioned, most of it is intervention related topic, but exciting topic, and everything is up to date. Everybody enjoy the virtual top 10.
Yeah, so actually one question already started, and I'm very happy to since the presentations are in the video format, for participants to download those slides are difficult. So what we will do is we'll ask all our speakers to give the PPT, PowerPoint or PDF file of their presentations, and will be made available for the participant. Yesterday, actually, there were 238. We expect top that number, but today is Sunday. Sunday is hopefully more participants. And I mentioned that questions are very important, knowing that no physical presence, but we really want to answer all the questions. Relevant questions, please post them. And then you will receive an email from the CME after the conclusion of the course with instruction on how to take evaluation, receive your CME certificate. Very important. And also that at the conclusion, visit the exhibit hall, and you'll see how this exhibit organizers have created a nice, the product specification and various details of it. So yes, slides will be available besides the whole presentation available, and we'll make all the slides available for our participant. With that note, I would say we are ready to start. And as you see, we keep the same pattern what we did yesterday. 5 topics related to clinical cardiology, and 1 topic out of the context but relevant. Yesterday, the first lecture was given, as you remember, that Dr. Dipti Ichaporia on the new strategy direction of ACC. I felt it's appropriate now in this era to talk about how the hospitals are surviving in this COVID-19 crisis. So that Dr. David Rich, who is the president and chief operating officer of Mount Sinai Hospital and Mount Sinai Hospital in Queens, will be giving the lecture on the hospital financial health post-COVID-19 innovative strategies. I just want to say, Dr. Rich started Mount Sinai in 1984, then ascended, became chief of anesthesia, and then ultimately the president of Mount Sinai Hospital, where he has done a tremendous job. In this COVID time, came to the hospital every day, really strategized where at a point where hospital was flooded with COVID patients to provide the best and appropriate care and protecting both patients, employees, physicians, and did a tremendous job. He has been a lot of academic activities also, achievements, including writing, he's a co-writer on a few books of anesthesia, but very important that from operational point of view, how to deal with the COVID-19 from financial point of view, he has a good insight to share with us. So therefore, Dr. David Rich.
Hello, everyone, and thank you so much for coming to this clinical cardiology conference. It is an incredibly important conference for Mount Sinai. We've enjoyed doing this for so many years, and you're all quite welcome. Thank you for joining us. I'm going to be speaking a little bit about the crisis in COVID-19 at Mount Sinai Health System, and all along the way I will give some description of the financial implications of all of the items that we speak of today. So Mount Sinai Health System is 8 hospitals located throughout New York City and Long Island with greater than 4.1 million annual patient visits, greater than 410 ambulatory practices, over 42,000 employees, affiliated with 1 school, the Icahn School of Medicine at Mount Sinai. This slide provides quite a timeline for us to look at, showing how the crisis unfolded from the time that when we all became first aware of COVID-19 through June 8th, when we began elective surgical procedures again. So beginning in early January, the health system became aware of COVID-19 along with everyone else, and we began our first internal drilling and emergency operations center preparations. On February 7th, we had our first COVID town hall. On March 5th, we converted our first ICU to a COVID ICU with negative pressure in all of the rooms. Following the first case that was diagnosed in New York State, it was an ambulatory couple of physicians, actually, who were tested at Mount Sinai Hospital on February 29th. By March 9th, we had our first Mount Sinai Hospital COVID-19 admission. And by March 15th to 17th, we'd expanded our laboratory to do in-house testing for both viruses and antibodies. We'd imposed visitor restrictions, universal masking, contingency standards for N95 respirators, and we'd halted elective procedures. So at that point, economically, The revenue had stopped coming in because there was very little in the way of elective procedures. Although we were well reimbursed for the COVID patients and there was some government support, it is overall a less margin generating activity than what you see with elective surgical volume and elective cardiac procedural volume. By March 22nd, New York was on pause. By March 30th, visitor screening for labor and delivery, and we liberalized N95 distribution, meaning that our expenses for PPE were dramatically increased as we had to distribute as many N95 masks as we could have, rarely ever having more than 2 or 3 days supply on hand. We did major construction in our lobby spaces to create non-traditional space, and also I will note that on April 1st, we opened tents in Central Park in collaboration with an outside organization that had the capacity to treat up to 68 patients in hospital tents that were normally intended for the third world. By April 4th to 7th, we were at the peak with over 2,000 patients in the health system, over 700 at Mount Sinai Hospital. By April 8th, we'd opened up a COVID-19 palliative care unit because we had so many patients who were so ill in the ICU that some of them had moved into a palliative care status. By April 14th, we actually opened our lobby for some care also by the same team that was taking care of patients in the tent, but we also were able to reopen our first non-COVID unit because the non-traditional spaces were able to decant. So what were our major challenges? Increasing capacity. Critical care capacity required we have more negative pressure rooms than non-traditional spaces. It involves switching most of our ambulatory care to telemedicine. Workforce management, we had to expend a lot of dollars to fix the supply chain for PPE and for ventilators, as we'll get into. Staff training and engagement. Communication was probably the least expensive because that's mostly electronic. Redeployment of staff away from areas such as psychiatry or radiology and pediatrics into the adult hospital, and moving to a team-based model of care to support our nurses. In-house testing, ventilator acquisition and management, extracorporeal membrane oxygenation, and increasing the level of therapeutics all required additional expenditures. And then, of course, our own in-house testing was necessary so that we could more appropriately use personal protective equipment, and doing this in-house decreased the turnaround time to under 12 hours from 6 to 7 days for external assessments. Patient placement was very challenging, increased our expense because it was difficult to get patients out of hospitals to nursing homes or LTACs, and staff engagement was always a challenge because of the factor of our staff being, frankly, appropriately frightened by this very challenging situation. The curve flattened in New York in the middle of April, and by May we were down to very manageable levels, and by June there were less than 10 patients at Mount Sinai Hospital. So that actually worked out very well for us, although the decline from the peak was very, very protracted, but the staff did very well. Now, we also had to work very hard to increase ventilator capacity using innovative techniques such as non-traditional ventilators. We used anesthesia machines, transport ventilators, and specialty ventilators, launched a centralized assembly, testing, and distribution of devices for the health system. We probably spent in excess of $10 million in purchasing extra respiratory devices in our health system. We also leveraged our simulation laboratory to facilitate innovations such as upgrading home ventilators, which were a several hundred pool backup for the health system in case we ran out of critical care ventilators. And we also developed a ventilator splitting protocol, including 3D printed valves. ECMO was prepared and ready to go. We did use it on a certain number of patients. The outcomes were not wonderful in those patients, unfortunately, but we believe it's a very important, albeit expensive, technology to have for patients who have end-stage lung disease that may either recover or potentially be referred eventually for lung transplant, but obviously recovery pathway is the desired outcome. Now, this is getting towards the end. You can see this positivity rate for tests. Originally, we're about 2/3 positive at Mount Sinai Hospital and elsewhere in the health system because we were only testing sick patients in the hospital. But as we began to test our community and others who are ambulatory, we see that the testing positivity rate decreased to consistently in the 1% range where it has remained. In terms of treatment recommendations, we additionally had a lot of expense related to creating a process of convalescent plasma administration. These are data on our first 39 patients showing improved survival. And the health system probably has one of the largest experiences in the US with over 550 patients transfused. Very expensive and logistically challenging to set up a convalescent plasma program, but we felt it was essential. Antivirals in the form of remdesivir are not really easy to obtain initially, but over time, with allocation and equitable prescribing, we were able to best manage within our population. And we did SARS-CoV-2 directed antibody therapy, as I noted, and clearly anticoagulation was a huge benefit to us. This is the anticoagulation slide showing that there was improved survival. These are data from Mount Sinai itself showing that early anticoagulation is associated with decreased progression to intubation and also decreased mortality. Bleeding rates were low but marginally higher with therapeutic anticoagulation compared with prophylactic. This is the key to the economics. The absence of elective surgery during the middle of March through the middle of, really the middle of May, and then a gradual increase until we were back to near normal levels, really from July, although there's still some recovery that has occurred in multiple areas over the months of July through September. So I want to end by thanking the healthcare workers at Mount Sinai. They were absolutely tremendous. Our cardiology team dropped everything else that they were doing and they became critical care physicians. They used their anticoagulation expertise to change the course of care for COVID patients, potentially not just at Mount Sinai, but worldwide. And we're very proud of what the team was able to do. Several $100 million were expended on this process. And in the absence of federal funding, this would have translated to several $100 million of loss for the health system. We do not know exactly where we will end up after federal support, but suffice it to say that managing the COVID crisis was extraordinarily expensive and ongoing expenses continue because of reduced capacity related to the needs for social distancing, fewer people in our holding areas, conversion to partial telehealth, and of course, not complete return of all elective procedural volume related to the ongoing nature of the crisis and the fear that we have in our patient population. Thank you so much for listening to this introductory lecture.
This really gives us the bird's eye view, what we went through, and hopefully the second wave will not come. But yeah, those who are in this field have seen that some patients have started coming back. Well, now we go on to our main agenda of selecting 5 top topics. So we start with Time to Treat the Vulnerable Plaque by Greg Stone. As you know, all you know, that Dr. Greg Stone is an internationally renowned interventional cardiologist and joined Mount Sinai mid last year as a director of academic affairs for the health system and has done a tremendous job. And the job actually is appropriate for him with his excellent nature, excellent leadership in this field of interventional cardiology, where he has done a numerous well-designed trials, brought the drugs and devices for clinical use, and we are so proud of him. Over 2,000 papers, numerous scientific advancement, and the lectures, invited lectures, and so. And he also is the co-director of TCT and CRF, which is the major, as you know, the TCT is the major meeting of interventional cardiology. I'm so proud that he is now part of Mount Sinai Health System, and he will be talking about the time to treat the vulnerable plaque, because this is one factor which people keep asking, that what do I do so that I don't develop the acute coronary syndrome? So hopefully he'll give us insight into where we are in this field. So Greg Stone.
Hi, this is Greg Stone from the Mount Sinai Heart Health System, and it's a pleasure today to speak to you about vulnerable plaque, diagnostic, and treatment options. These are my disclosures. So first, let's start by saying that we've made tremendous progress in the treatment of patients with cardiovascular disease. This was an article that was published a few years ago by Betsy Nabel and Eugene Brunwald in the New England Journal, looking at the decline in deaths from cardiovascular disease in relationship to scientific advances. And the first thing you can see is that we used to be having around 400 to 500 deaths per 100,000 population due to heart disease. And in the United States, that has markedly decreased to about 2010 to about 100, so about an 80% decrease. And they link this to a lot of important scientific advances, including revascularization therapies with both PCI and bypass surgery, statin treatment and other preventative therapies for atherosclerosis, treatment of acute myocardial infarction, such as with primary PCI. So we've made tremendous advances in both the primary prevention, secondary treatment, and secondary prevention of heart disease. But that being said, we're not done yet, because cardiovascular disease still is the #1 cause of death in the developed world, responsible for almost 1 in 3 people dying in the entire world, dying of cardiovascular disease. So about 18 million deaths per year. And in fact, if you look at some of the most recent vital statistics from the United States, we actually have reached a plateau in cardiovascular mortality. I showed you the great curves up to 2010, but since that time, we've really plateaued. And in fact, there's a little bit of a suggestion that we may actually be increasing in cardiovascular mortality in the last few years. So what we need to do is focus on both treating patients with cardiovascular disease, especially the end-stage manifestation, which is acute myocardial infarction, and we have to do even a better job preventing it. Now, we know the pathophysiology of acute myocardial infarction in most cases is a ruptured plaque with a occlusive thrombus. And we know from 23 randomized trials of primary PCI versus thrombolytic therapy that we've gotten pretty good at treating this disease with an invasive interventional approach. We can reduce mortality, reinfarction, recurrent ischemia, length of hospital stay, we improve LV function, etc. On the other hand, we don't do such a great job with primary prevention, in particular when we focus on revascularization of patients with stable coronary disease. Most patients with, quote, heart disease present with symptoms of stable coronary disease, such as angina or exercise limitation. And here we have a very different pathology. Rather than a thin cap fibroatheroma, we have more pathologic intimal thickening, and I'll talk more about this in a few minutes. And most studies to date have shown that if we revascularize patients with stable coronary disease, we can improve symptoms and quality of life, but we don't prevent heart attacks and we don't prevent cardiac death. Most recently, this was really shown in the ischemia trial, which I was one of the principal investigators. And this was a large-scale trial of 57 to 5,800 patients with stable ischemic heart disease and with moderate to severe ischemia. And revascularization in these patients compared to just ongoing medical therapy was ineffective at preventing cardiovascular death or myocardial infarction. Now, we do know that when we take patients with mild or diffuse coronary disease, they do have a risk of suddenly progressing to an acute coronary syndrome, either unstable angina or myocardial infarction or even sudden death. And this happens from angiographically appearing mild plaques, which then apparently suddenly progress. This was perhaps best pointed out in the early 2000s from the NHLBI dynamic registry of patients who had undergone catheterization. About 6% developed an unstable, rapidly progressive plaque within 1 year. And these are, again, are most commonly from angiographically mild plaques. And these have been called vulnerable plaques. These are plaques that typically don't produce ischemia, but place the patient at risk for sudden death and acute coronary syndromes. And we've learned from pathologic studies that these types of plaques that cause MI and sudden death are most commonly what are called thin cap fibroatheromas. And that is there's a lipid-rich necrotic core consisting of dead cells, cholesterol esters, which is separated from the lumen by a very thin fibrous cap. And this is a very metabolically active lesion. In the setting of systemic inflammation, this cap gets infiltrated with macrophages and matrix metalloproteinases and other compounds that will digest that cap and lead to rupture of the fibrous cap. And that will expose the underlying necrotic core, which is very prothrombotic. It releases tissue factor and other prothrombotic compounds. And that can lead to a sudden development of a thrombosis on what was a non-occlusive plaque. So this is often made the analogy that this is like a volcano waiting to happen. And as you know, when you see a volcano, you don't know what's going on behind the surface. Well, this is actually a sagittal section of a vulnerable plaque. And you can see this well-formed necrotic core, which is lipid-rich, cholesterol esters, barely being held from breaking through to the surface by this thin fibrous cap, just like a volcano. And you know what happens with these metabolically active volcanoes. Now, unfortunately, it's not quite this simple. There are other morphologies that can cause acute myocardial infarction and sudden death. While plaque ruptures probably cause 60 or 70% of them, there's a substantial number that are caused by plaque erosions, which are glycoprotein-rich plaques that actually don't rupture, but they can have a thrombus form on top of them because of an eroded surface. And then a small percentage of patients might be these calcific nodules that cause enough turbulence and platelet activation to lead to thrombotic occlusion. So can we detect vulnerable plaque? And if so, can we treat it? Well, there have been both candidate non-invasive and invasive diagnostic techniques. And I'm going to speak mostly about the invasive techniques because that's been my particular area of research. But the non-invasive techniques are very important because they could potentially be used for general population screening. And at the top of the list of these is multi-detector CT or CT angiography. But there's been a lot of work also done with magnetic resonance imaging or angiography, with or without contrast media, with agents to detect inflammation or neoangiogenesis or oxidation-rich lesions and thrombosis, such as monoclonal antibodies. There's been other nuclear imaging tests, such as with SPECT or with PECT, that have been able to detect other matrix metalloproteinases or VCAM or annexin, CD40 ligands, other components of the so-called vulnerable plaque. And then there's also near-infrared imaging as well. But the most of the greatest attention has been paid to multi-detector CT or CTA, which of course is very widespread. And the hallmarks of this are when you see plaques that are low attenuation, but positive remodeling. And they're usually moderate in severity, so they're not ischemia producing. So these patients are often symptomatic. There are other signs as well, such as the napkin ring sign. And when you see these low attenuation, positive remodeling plaques, the seminal work, which was done by Jaganarula and Motoyama and their colleagues, have shown that these types of plaques place patients at risk for acute coronary syndromes. And this can be a risk of anywhere from about 2 to 5-fold, depending on whether 1 or 2 high-risk plaque features are present. So if you take a patient like this, a high-risk plaque and a proximal LAD, it's about a 40 to 50% stenosis, but it's got low attenuation. You can see it's positive remodeled, and there is what's called a napkin ring sign. You can see the SPECT is negative. So this is not an ischemia-producing lesion, but nonetheless, within 1 year, this caused an ST segment elevation myocardial infarction right at the site of this lesion. Now, when we look at intravascular imaging, we actually have a higher signal-to-noise ratio to take advantage of because we can put an imaging transducer right next to the plaques in the coronary tree. And there have been 4 basically FDA-approved imaging modalities which can be useful to detect the morphologic and or chemical characteristics of vulnerable plaque. That's grayscale intravascular ultrasound, which relies on a dynamic range imaging of ultrasound parameters of a plaque to detect the grayscale characteristics of the plaque. If you add radio frequency imaging to grayscale, you get radio frequency IVUS, and you can color code the plaque components, as you can see here. We can get much higher frequency resolution by, instead of using ultrasound, by using light, particularly optical coherence tomography. And this can give you resolutions of around 10 to 20 microns compared to about 150 microns with ultrasound. And it's the only technique that actually has the resolution to be able to measure fibrous cap thickness. And then finally, there is near spectroscopy, near infrared spectroscopy, which is the most accurate technique to actually detecting lipid. And these are all FDA approved techniques. And you can see with NIRS, yellow is lipid and red is not lipid. So if we start with virtual histology, that's radio frequency IVUS, this has been extensively studied. And based on the morphology of these lesions, you can characterize them to either being fibrotic, fibrocalcific, pathologic intimal thickening. Those are what we would be considered to be the stable phenotypes. Then you could have atheromas, and fibroatheromas, which is the red plaque, are the necrotic core. That's the lipid deposition. And if there's separation of the fibroatheroma by green fibrous or fibrofatty tissue, that's called a thick cap fibroatheroma. If you don't see such a cap, that's called a VH, virtual histology, thin cap fibroatheroma. And these are the ones that are presumed to be at the most high risk, although by not being able to see the cap with IVUS, it really just means it's less than 150 microns thick, where we really think that most thin plaques, most thin caps are really less than 65 microns thick. Nonetheless, we tested this in the first large-scale prospective multimodality imaging natural history study of patients with coronary disease. And this was called the PROSPECT study, which was published in 2011 in the New England Journal. And we took 700 patients with acute coronary syndromes, and they had all their culprit lesions treated. Those were the lesions causing the ACS, such as ruptured or thrombotic plaques, as well as other severe stenoses. And then once that was successful, they were formally enrolled in the study, and they went 3-vessel imaging. And they had angiography performed of the entire coronary tree, where we did QCA and measured every single millimeter. And they also had 3-vessel intravascular ultrasound grayscale and radio frequency virtual histology. And so we looked at basically every half millimeter of the coronary tree with very detailed imaging. Based on this, we prospectively characterized over 3,000 lesions, and then we followed them for up to 5 years to look at the outcomes of the patients. And then based on follow-up angiography, we adjudicated whether the problems that occurred at original lesions with different types of characteristics. And our hypothesis was that the VH TICFAs were going to be the ones that were at highest risk. So this is what we found when we followed these 697 patients with acute coronary syndromes. Over 3 years, 20% of them, or about 1 in 5, developed an acute coronary syndrome. Now that problem, based on angiography, about half of the time arose from one of the originally treated lesions. Those are what we call the culprit lesions. And that could have been from stent restenosis or stent thrombosis. But about half the time as well, they arose from untreated non-culprit lesions. And these were atherosclerotic plaques that appeared angiographically very mild. In about 2% of the patients, they had an event, but most of these were sudden deaths, so we didn't have an angiogram, so we couldn't tell where the event came from. Now, when we looked at a multivariable predictors of non-culprit lesion-related events, what were those plaques like at baseline that caused the problem? We found out that even though they appeared angiographically mild, they had a lot of plaque burden. They actually, and if they had plaque burden greater than 70%, that with a multivariable hazard ratio of 5-fold predicted a future major adverse cardiac event arising from that individual lesion. The second individual predictive factor was a VH TICFA. So the hypothesis did hold. That placed those lesions at 3.35 in increased risk. And the third predictive factor was a small minimal luminal area. And again, these were mild appearing lesions. So plaque burden was the most powerful predictive factor. And if you took those 3 factors, high plaque burden, small MLA, or a TICFA, thin cap fibroatheroma, you had 1,650 lesions with none of those characteristics. And in a median 3.4-year follow-up, the MACE rate was 0.3%, incredibly low. Those were very stable plaques. If you had 1, 2, and 3 of those characteristics, on the other hand, you would then identify lesions with a 10 to 20% risk of developing into a MACE within 3 years. So the first thing is, if you don't have those characteristics, that's fantastic. That's almost the best deferral tool ever. And that you can really reassure a patient that those lesions are not at risk. But if you do have 2 or 3 of those high-risk characteristics, now you've got a 1 in 10 to 1 in 5 chance of that particular lesion causing either a cardiac death or myocardial infarction, or rupturing to cause unstable angina or severe progressive angina. And plaque burden, as I mentioned, was the #1 predictive variable. And again, it was really an exponential curve. There were thousands of plaques with less than 40% stenosis, and not a single one of them caused an event. But when you got up to greater than 60, and then particularly greater than 70, those were the high-risk plaques. And overall, these plaques that caused an event had a baseline diameter stenosis of 32% by angiography. So these are very mild appearing, and you just can't tell how much plaque is there. So they've got a lot of plaque, but they're very mild appearing. So we really exploded the myth in Prospect in that vulnerable plaques are not mild plaques. In fact, they are severe plaques. They just look angiographically mild. So it's very important that we stop relying on the angiogram and we use either a non-invasive or invasive imaging test, because the angiogram only shows the lumen. We need to know what's in the wall of the artery. But it's more than just knowing how much plaque there is, because this is all the high risk, this is all the large plaque burden plaques in Prospect, all of the ones with a plaque burden greater than 70%. And you can see that if they were greater than 70% and a TICFA, now you had a 16% risk of having an event at about 3 years. If it was a thick cap fibroatheroma and a large plaque burden plaque, this was intermediate risk, and it had an 8.7% risk. And if it was a garden variety plaque without a fibroatheroma, then you can see that wasn't risky at all, even if it had a plaque burden of greater than 70%. So we need to know the composition of the plaque as well as its size. Now, another way to get at the composition of the plaque, which is an easier technique to apply than virtual histology, is near-infrared spectroscopy. And this is not an imaging technique, but it's a spectroscopic technique that looks at tissue and can very accurately identify cholesterol and cholesterol esters according to the reflection of light that's sent out from a transducer and reflected back from a particular plaque. And so here, for example, you have an autopsy specimen, and here you can see a patient that's got 2 necrotic cores, and that turns yellow. Here's a patient with just pathologic, a section of the same artery with just pathologic interval thickening. It's red. Here's a second part of the same artery that's got 2 necrotic cores, and it's yellow, and another area that looks, just again, mild plaquing without a fibroatheroma, and it's red. And so this was approved by the FDA as actually the most accurate spectroscopic technique to identify any sort of tissue type in the body. So the utility of this technique was tested in a prospective study called the lipid-rich plaque study. And they performed near IVUS, near infrared spectroscopy with grayscale intravascular ultrasound in 1,271 patients with a variety of different coronary syndromes, from stabilized STEMI all the way to stable coronary disease. And they looked at the 2-year rate of MACE, again, according to the lesion types. And you can see they found that about an equal number of these adverse events over 2 years were caused by non-culprit lesions compared with previous treated culprit lesions. And when they looked at to see whether or not this lipid detection could identify those lesions that were likely to cause a MACE event using a similar methodology that we did in Prospect, if there was greater than 40% lipid, then those plaques had a hazard ratio of about 4.22 being more likely to cause a MACE event. And in a multivariable analysis, you could see large lipid burden as well as large plaque burden, and in addition to a small MLA, were very predictive of lesion level events. So here is, for example, a circumflex artery that was treated medically, and you can see this moderate stenosis proximally, very mild stenosis more distally. And when they did intravascular ultrasound, you could see the plaque burden was moderate. It was about 62%. But here you could see one particular area had a very high rich yellow spot, 472 measurement, which is 47% lipid. And what happened exactly at that spot? You could see 1 year later, the patient ruptured a plaque and came in with an unstable angina with a subtotal stenosis. If you looked at a patient level, any patients that had one or more of these plaques also had a doubled risk of having an adverse event. So both on a plaque level and on a lesion level, finding lipid-rich plaques predict future acute coronary syndromes. So we have been working now for better than 7 years to actually validate this and take this to the next level with somewhat more robust methodology in a study called Prospect 2. And here we're taking 900 patients with acute coronary syndromes, where once again, after treatment of culprit lesions, we're performing 3-vessel, NIRS, and IVUS. But what's different than in the LRP study is that we are prospectively characterizing every single plaque, and then we're following them longitudinally to determine the individual plaque characteristics that place these patients at high risk. And we're very excited that enrollment closed in December of 2018 with 901 patients, and we'll be presenting this in just a few days at TCT 2020 as a late-breaking trial. So we hope you'll come watch this. And then, so the question is now, can we identify vulnerable plaque? And the answer is yes. Using grayscale IVUS, radiofrequency IVUS, and from the LRP study, near-infrared spectroscopy, and even possibly OCT, we can identify plaques that place patients at risk for future adverse cardiovascular events. So the question, though, is once we find these plaques, since they're angiographically mild and they usually don't cause ischemia, what should we do about them? So here, for example, from a study called SCAPUS, which is 30,000 people in Sweden of mid-age undergoing just routine CT surveillance, here's a 61-year-old woman, previous smoker, otherwise healthy. And her CT showed a proximal LAD with what looks like a vulnerable plaque. It's a low Hounsfield unit. It's positively remodeled. So actually, they recommended that she undergo angiography. And here's the plaque. It's a 30% stenosis in the proximal LAD. And the IFR was normal, so it's not an ischemia-producing lesion. And they went ahead and did NIRS IVUS. And you can see this is a lipid-rich plaque with a maximum amount of lipid of 51% lipid. And when you look here, there's a lot of plaque burden, 74%. So for most of our data, assuming Prospect 2 confirms this, we would think that this patient would probably have about a 1 in 5 chance within a few years of having an adverse event. But the patient's already on a statin. Should we stent this? Should we put the patient on a PCSK9 inhibitor? What should we do? Well, we don't really know. We know that one of the ways that statins and PCSK9 inhibitors do work and do reduce the risk of cardiovascular death and MI is by stabilizing vulnerable plaque. And statins have been actually shown to thicken the thin fibrous cap on top of lipid-rich lesions. We can also do that, at least experimentally, by putting in a stent. And if you put a stent in, it invokes a certain amount of neointima, and that neointimal coverage will actually create a new fibrous cap, or what we call a neocap, which can actually thicken the old thin fibrous cap. But is it safe to stent these vulnerable plaques? Well, obviously, we would need randomized trials. There's been a lot of preliminary work done, especially with bioresorbable scaffolds and metallic drug-eluting stents, and you can see when you stent plaques, you get over 6 months and then 24 months new coverage that can take a thin cap and thicken the cap, about 150 to 200 microns. We know that we can take lesions that have very high wall stress, And we know that's a risk factor for atherosclerosis progression in the low areas of wall stress for plaque rupture as well. And by creating that neocap, it stabilizes the wall stress and equalizes across the lesion. And bioresorbable scaffolds are particularly attractive in this application because not only do they create the neocap, but then they allow the lumen to continue to enlarge over time. So we've designed a study within Prospect 2 called the Prospect Absorb randomized trial. And within the 900 patients that we've enrolled in Prospect 2, we're randomizing up to 300 patients with a lesion that's at least 65% plaque burden, which in and of itself induces high risk. And we're randomizing those lesions to an absorbed bioresorbable scaffold versus medical therapy alone. And all of those patients are undergoing routine follow-up imaging at 2 years to see if safely we can enlarge the plaque lumens and thicken the fibrous cap. And once again, we finished that study, and the Prospect Absorb randomized trial will be presented at TCT within a few days. So please pay attention. There's one other study going on of the interventional treatment of vulnerable plaque, which is a larger study, 1,600 patients in South Korea, where they're taking vulnerable patients and vulnerable lesions and then randomizing them to either a stent or a scaffold versus medical therapy. And this trial has enrolled about half its patients. So I'll close with this slide. Should we treat these lesions? This was a 65-year-old man who presented in clinical practice. He had exertional dyspnea. He was a prior smoker. He had hypertension and hypercholesterolemia. He had a pretty low LDL already on atorvastatin. He had a stress test which showed a millimeter of exertional ST depression, but normal resting and stress ejection fraction. So kind of borderline for ischemia. So his doctor recommended an angiogram, and here's his angiogram. And he had a mild stenosis in his LAD, proximally, a mild stenosis in his mid-LAD, and no other lesions anywhere else in his coronary tree. So the doctor did an FFR to see if this was an ischemia-producing lesion because of this borderline stress test, and the FFR was 0.88. So there's no ischemia in the LAD. He then wanted to characterize these lesions, so he performed near-infrared spectroscopy and intravascular ultrasound. And both of these lesions were very lipid-rich, anywhere from 36% to 57% lipid-rich, and they both had high plaque burden, 71 to 74%. But you can see how mild this looks. So the patient was already on high-dose atorvastatin and already had a low LDL. So what should we do for this patient? Should we put him on a PCSK9 inhibitor, or should we stent these lesions? So I think we would not stent these lesions today. Today, this patient was treated with a PCSK9 inhibitor, which again has a very low side effect profile, and his LDL was brought down below 30. But once we see the results of Prospect 2 and the PREVENT randomized trial, maybe we'll be considering the prophylactic interventional treatment of vulnerable plaques in the future. Thanks very much.
Yeah, so just a fantastic presentation by Dr. Greg Stone. Exactly what we are looking for and how to treat this vulnerable plaque. Answer may be in next few weeks after we learn from the results of the Prospect 2 trial. Now moving on to the next topic, and by Dr. Roxana Maran on anti-thrombotic therapy update, because question always comes 2 versus 1 antiplatelet therapy post-PCI or 3 versus 2 post-PCI and AFib, whether it should be dual therapy or triple therapy. As you know, Dr. Roxana Maran is the professor of medicine and director of interventional cardiovascular research and clinical trial at Mount Sinai Medical Center, and a very prolific, internationally renowned, most highest sought for interventionalist for moderation, and of course, a very great academician. Numerous papers to her large portfolio every year. Almost 100+ papers are produced on a very high impact journals. And she has done a terrific job for Mount Sinai as well as for American College of Cardiology, where she's board of trustee in various meetings. She has held a few positions there, and also for Society of Coronary Angiography and Intervention. Right now, she has created another niche for women in intervention and promoting this field, which is very crucial at present to advance in various aspects of medicine. She also received the Jacobi Medallion Award And I'm so proud that Dr. Roxana Mehran did her cardiology and interventional cardiology at Mount Sinai and came back and with us over 10 years. So her field has been the bleeding, the antiplatelet, antithrombotic therapy, and CIN. And this is the right topic for all us to understand where we are in rapidly changing interventional field in terms of antiplatelet and antithrombotic therapy. Here is Dr. Roxana Mehran.
Thank you, Dr. Sharma, Dr. Kinney, Dr. Narula, for inviting me to the top 10 topics in cardiology and for including antithrombotic therapy update in there. It's really a pleasure. Important for you to note my disclosures both to the institution and to myself and my spouse. Today, I'll talk about two topics as requested by our course directors: DAPT versus single antiplatelet therapy after PCI, and then triple versus dual therapy after PCI in patients with atrial fibrillation. So antiplatelet therapies are needed both in primary and secondary prevention and have been incredibly useful in preventing ischemic events tremendously, even in subclinical atherosclerosis, but very importantly in secondary prevention, especially after PCI. And we've seen this play over and over again, especially in terms of stenting, where dual antiplatelet therapy now have become the cornerstone of treatment of patients who receive stents, whether it's drug-eluting stents or bare metal stents. And a lot of it has to do with the stent scaffolds and the important nidus for thrombus formation, et cetera, especially early on, right after stenting. And if we all remember back in 2006 with the first generation DES, where we saw stent thrombosis as an important event that was happening in patients with first generation drug-eluting stents, and the firestorm that came from that in 2006, where there was increased deaths in patients receiving drug-eluting stents, and which called for longer-term dual antiplatelet therapy durations, and the panel that then gave a 12-month duration of dual antiplatelet therapies for all DES at that time, which was all first-generation DES. And we all know that drug-eluting stents have had some of the bitter and sweet, no restenosis, fantastic. In that first generation, there was a important delayed healing, inflammation, incomplete apposition, and so a lot of issues in that first generation DES. But let me tell you that a lot has changed since that first generation DES. We now have advanced stent technology with thinner struts, different kinds of biodegradable or even fluoropolymers that are thromboresistant, intravascular imaging to enhance and improve the best possible results that we could get in the most complex lesions, the potent antiplatelet regimens that we now have at our armamentarium, prasugrel and ticagrelor, and then, of course, very, very important, excellent, improved secondary prevention strategies with statins and PCSK9 inhibitors, and, of course, other therapies that we give our patients to prolong their life. No question that the early versus current generation DES have made a tremendous impact in this current generation DES with reducing death and MI, and a very, very important, wonderful result with the current generation DES, such that in 2017, the European Society of Cardiology, irrespective of the intended dual antiplatelet therapy duration, made DES the preferred treatment option with a class 1A recommendation. But the duration of dual antiplatelet therapy, especially in those patients with high bleeding risk, is very much unknown. 1 month, 3 months, 6 months, how long? And shorter is probably better in most patients because bleeding matters. And the important comparative impact of bleeding versus myocardial infarction on mortality is something for us to that has paid a lot of attention in the recent years, in the last decade, really changing our focus from stent thrombosis now into not putting patients at a very high risk for bleeding to bleeding avoidance strategies to help mitigate that risk. And of course, understanding that myocardial infarction and severe or major bleeding are both important and attribute to deaths. And in fact, there are some kinds of bleeding that are much, much worse than myocardial infarction, spontaneous myocardial infarction, which is a very, very important predictor of mortality. And here's some work from Marco Balgimigli showing that BARC3C and greater, those are really, really, really important bleeds to be avoided. And that trade-off is incredibly important, such that you're seeing a similar BARC3 and MI, both are very, very similarly important, but when you get to BARC3C and above, it becomes even much, much more important. Because when the patient bleeds, there are important consequences. We stop their dual antiplatelet therapies, and then there is this rebound platelet activation. And with an incomplete stent apposition or endothelialization, you can end up with stent thrombosis or MI, the very thing you're trying to avoid. And in bleeding, where there is transfusion and there could be inflammatory biomarkers that give a really important predictor of mortality, and then just that whole extravasation of blood, dropping the hemoglobin, and these all could lead to the very kinds of things that we're trying to avoid. So it becomes very, very important for us to balance the ischemic and bleeding risk. And the more potent means more efficacy. But is that correct? Should we always be thinking in that direction? Or what about when we're stacking therapies on each other? What harm are we enduring? Well, it made us kind of sit back and think about the role of aspirin. There are real important uncertainties around the use of aspirin for secondary prevention. Three major arguments challenge the use of aspirin for secondary prevention in combination therapy with other antithrombotic regimens. And a lot of it has to do with the bleeding risk, the current novel antithrombotics that could really are potent enough that really make aspirin a non-player. And then very important other risk reduction therapies that may question the need of aspirin. And then, of course, very important issue about the P2Y12 inhibitors as the alternative therapy that may very well have an important signaling effect on thrombotic and inflammatory process. And there is wonderful clinical efficacy of P2Y12 inhibitors to reduce stent thrombosis. So this understanding of kind of thinking about maybe dropping aspirin, especially when you have a potent P2Y12 inhibitor, is not a new concept, even though everyone thinks of it as an innovative concept. It really has been around a while. Here's work that has been shown. This is a really interesting work that tells you that aspirin might actually abolish or decrease the antithrombotic effect of P2Y12 receptor blockers in vivo. That's mediated by the amplification of antiplatelet effect of inhibitory prostaglandins like PGI2. And in the presence of P2Y12 inhibitors, aspirin provides very little or no benefit at all. And this has been well documented with both prasugrel and ticagrelor before we even did any of these big studies. But nevertheless, our Japanese investigators with the STOP2 trial with a single stent platform, this was all Zion stent patients with 1 month DAPT versus 12 months of DAPT. And in the 1 month dual antiplatelet therapy, instead of dropping the P2Y12, they actually dropped the aspirin after 1 month and continued with clopidogrel monotherapy compared to aspirin plus clopidogrel, and looked at the 1 year outcome. And what was really interesting is that the net adverse clinical events were in favor of a monotherapy of P2Y12 monotherapy after 1 month of DAPT, driven mostly by reduction of bleeding, no difference in the ischemic endpoint, and a very, very interesting and important outcome in this 3,000 patient study. The Smart Choice investigators used 3 different stent platforms, and here they went between 3 to 12 months of DAPT, once again going to a single P2Y12 inhibitor, and they showed very, very nicely death MI stroke at 12 months in this 3,000 patient study to be very, very similar and non-inferior. And in fact, the bleeding was significantly lower with a shorter duration of DAPT. So here it is with just clopidogrel monotherapy. And I'd be a little bit nervous because clopidogrel non-responsiveness is prevalent in certain patient populations. And I would like to test patients, but still, despite that, here they were able to achieve this great results here in Korea and in Japan. But the global leaders investigators did the largest ever all-comer study, 16,000 patients who were randomized to an experimental arm of aspirin plus ticagrelor for 1 month, and then ticagrelor monotherapy for the next 23 months versus the control arm, which basically took the convention of what we were doing with our ACS patients with aspirin ticagrelor for a year and then aspirin monotherapy versus the stable patients getting aspirin and clopidogrel for a year and then going to aspirin monotherapy. They looked at the composite of all-cause mortality and Q-wave MI up to 2 years with a hypothesis that the experimental arm would be superior. I think a very lofty goal, and looking at the investigator-reported non-adjudicated BARC 3 and 5 bleeding up to 2 years. They missed that superiority endpoint just narrowly, and unfortunate that this was a missed opportunity because in my mind, non-inferiority in the QMI and mortality is a win when you're dropping aspirin and going to a very simple ticagrelor monotherapy. But there was important issues here. The lack of centralized adjudication, investigator reports led to underreporting of a lot of these events. And the comparator arm, that reference group, having these multiple comparisons between ACS and stable patients made this study very difficult to interpret. But nonetheless, it gives you an opportunity to go after ticagrelor monotherapy. And we did this in the Twilight trial. At around the same time, we had designed the Twilight study. Here, we asked for high-risk patients who were at high risk for both ischemic and bleeding complications, and in whom the investigator or the clinician wanted to send that patient home on aspirin and ticagrelor using some of the, not just their choice, but also some bleeding and ischemic risk factor features that were included in the trial. These patients were given 3 months of aspirin and ticagrelor in an open label fashion, and at 3 months, they were randomized to aspirin plus ticagrelor, continuing that for another year, versus ticagrelor plus placebo. And then they were evaluated at 15 months after the PCI or 12 months after the randomization for ischemic and bleeding endpoints. And what we found was an incredible reduction in BARC 2, 3, and 5 bleeding, with the numbers needed to treat of only 33 to reach this, and absolutely no difference in death, MI, and stroke. So this study showed a non-inferiority of death, MI, and stroke in over 7,900 patients, and with a fantastic ability to go with less bleeding and no increase in ischemic events out to 1 year with ticagrelor monotherapy. Then we had our investigators, the TICO trial, doing a very, very interesting work in ACS patient population. And here they randomized patients with acute coronary syndromes to ticagrelor, 3 months of ticagrelor, 3 months of DAPT followed by ticagrelor monotherapy versus 12 months of DAPT with ticagrelor plus aspirin. And here, what they found was a a major reduction in bleeding, and of course no difference in their ischemic output. So the overall net adverse clinical events was in favor of this ticagrelor monotherapy. And you can see the curves separating exactly at 90 days, driven by reducing the bleeding complications. The story is not complete without also placing prasugrel monotherapy as an important study. The ACID pilot trial is ongoing, and I think it's also going to give us another option with prasugrel. And the results are really, really interesting and showing that they were able to achieve good results. But again, this is a very, very smaller study, and we're really looking for larger trials. They did not see any stent thrombosis in this study, and it's very, very interesting. But at the end of the day, it's all about the balance. Individualized approach is the way to go. And what we need to do as clinicians is to give the right therapy to the right patient by evaluating their risk of bleeding and ischemic complications. When they are equal, we still need more data. We are really, really, here's where the equipoise, when both you have low ischemic risk and low bleeding risk, and then here when you have high ischemic and high bleeding risk, in both of these areas where there's overlap is when we need to use a tailored approach and really kind of thinking about ticagrelor monotherapy and these newer innovative approaches of de-escalation, et cetera, after the period of risk. But when you have a low bleeding risk, you should not shorten your duration of DAPT and actually increase it. And when you have a high bleeding risk, you can shorten that duration. So again, a very individualized approach is how we need to approach this. What about the biggest dilemma? A patient with atrial fibrillation. These patients that are at risk for the most devastating complication of stroke. Oral anticoagulation is seminal in treating these patients. And we do know that they also have an overlap of when they are when they have coronary disease and require stenting, dual antiplatelet therapies are needed. So what you end up having, about 5 to 10% of these patients undergoing PCI having atrial fibrillation, and for us having a very, very important issue of the hazard ratio of mortality by just having new onset AFib after PCI. These patients are at high risk. And how do we deal with this? Take a look at the number of patients of atrial fibrillation, 20 million of atrial fibrillation. Oral anticoagulation is indicated in about 16 million, for about 5 million with coronary disease, and 1 to 2 million requiring a revascularization. And the prevalence of atrial fibrillation will continue to grow. But what we need to do is to find ways to not to stack therapies on these patients. The synergy of oral anticoagulation and antiplatelet therapy are incredibly important for us to think about this dual pathway and finding ways to come up with a possibility of a treatment effect that would keep these patients free of the bleeding complications that that is so prevalent in this patient population. And if we look at the novel oral anticoagulants, it's a place to be for these patients for treating atrial fibrillation. Certainly, novel oral anticoagulants are protecting patients against the most devastating issue, which is hemorrhagic stroke. And of course, all-cause mortality is in favor of novel oral anticoagulants. So whenever possible, we should, if we have a patient who's still on Coumadin or VKA antagonist, we should really bring these patients and change them to a novel oral anticoagulant. And before we had WUST, and I'll discuss the WUST program, triple therapy was the standard of care. And look at the bleeding hazard of these patients, almost 4 times as likely to have a major bleeding episode. So we need to think about how to de-escalate therapies in these patients. And it was the WUST investigators in the Netherlands who did this by randomizing 573 AF patients undergoing PCI, where they just took out the patients and stopped the aspirin at the time of discharge, went to a dual therapy versus the standard of care. What they found incredibly is that these patients were obviously, even mechanical valves were included, most of them were atrial fibrillation, but very important results of this trial, which was published in The Lancet now almost 7 years ago, was that going to a non-aspirin treatment, dropping aspirin, reduced bleeding by 64%. And in fact, it reduced ischemic events. There was no signal of harm, and mortality was in favor of a dual therapy. Now, these endpoints are underpowered. We can't say you're benefiting ischemic events. You're certainly reducing bleeding without the ischemic harm. And the Europeans, their perspective in 2017 for the DAPT update, in patients with oral anticoagulants and PCI, there was no default strategy, and you had to consider bleeding versus ischemic risk. When you had the chance, in high bleeding risk patients, when you had that, you could go to a dual therapy and drop aspirin. But the duration of aspirin on the triple therapy, no matter where you are, is no more than a month. So really a shortened duration of aspirin therapy in these patients and dropping it. And this algorithm is also very similar to what we're doing in the North American consensus back in 2016, and where they are really coming up with a default strategy of about up to a month, and really going to this dual therapy for the majority of the patients, but those who are at high ischemic and thrombotic risk and low bleeding, giving up to about a month. And then for those at low ischemic but high thrombotic, low ischemic but high bleeding risk, going to a triple therapy for at least a month, or even sometimes 6 months in those patients. So it was really there for 2018, and we're now coming up with the 2020 updates for this consensus document. And we have so much more data now. First of all, we had Pioneer, we had Redual, we had WUST. All of these showed that dropping aspirin is the way to go. The Augustus trial was the trial that really took under consideration the evaluation of dropping the aspirin in a blinded, largest study ever. And they had two independent hypotheses of showing non-inferiority of apixaban to VKA for bleeding evaluation, and that the triple therapy is inferior to dual therapy in terms of these important bleeding endpoints. And 4,600 patients in a 2x2 factorial design with placebo embedded in here for aspirin versus placebo in a double-blind fashion, and showing such an important effect of dropping aspirin. When you drop aspirin, in whether you're on apixaban or in the VKA arm, you had a major drop in your bleeding complications. And the best possible scenario was if you gave the patient apixaban plus a P2Y12 inhibitor and no aspirin, the placebo arm, the lowest bleeding. And in fact, in terms of death and hospitalization, there was no real difference. You reduced bleeding tremendously when we dropped aspirin. And so since then, I mean, you can imagine the updated meta-analysis that has now come out. There have been two of them that have been published now. This one that I'm going to share with you is in the largest numbers, and you can take a look and see what's going on here. That the major adverse cardiovascular events are very similar, whether you go to a dual therapy or a single antiplatelet therapy in combination with a novel or a VKA. Very important. But bleeding is where you're gaining the best possible benefit when you drop aspirin. And no matter which way you look at it, in these patients, the sooner you drop the aspirin, the faster you will gain the results in reducing the bleeding complications. And in overview, This includes intracranial hemorrhage. And if you look, the thing you worry about the most is stent thrombosis. So we need to really still evaluate the risk of stent thrombosis. And if you look at the stent thrombosis numbers and put them all together, there was a little bit of a signal of harm, but it crosses the line of unity. And we're going to have to look at this on a case-by-case basis. So to conclude here, in patients with AF undergoing PCI, there are no significant differences in novel oral anticoagulant plus a single antiplatelet therapy, usually without aspirin, and VKA plus DAPT strategy in terms of major adverse cardiovascular events. But let me make sure you understand that it will reduce bleeding tremendously, and it will be an extremely helpful situation. The story of stent thrombosis will need a IPD, individual patient data analysis, that's going to take place here at Mount Sinai at the Icahn School of Medicine with all of our collaborators from all of these clinical trials. So I want to thank you for your attention, and thank you again for including me on this in this very, very fantastic symposium on the top 10 list in cardiology. Thank you for this.
Fantastic, masterful lecture by Dr. Roxana Mehran, and really to the point. And in a nutshell, that aspirin, which was the most favorite drug in CAD, PCI, is kind of disappearing. And there are a lot of questions which we'll come back to. One very important thing I need to point out, I did say that Dr. Mehran received Jacobi Medallion. She actually received bigger award than that. That is the Ellis Island Medal of Honor last year, which is given nationally to about 15-20 people. So with that note, thank you very much, Roxana, for a great lecture. Now we go to next one, is the cardiac contractility modulation at the intersection of EP and heart failure. As you know, the field of electrophysiology and heart failure, coming with the various devices and techniques, are kind of interchanging. And we felt this is the right topic for the latest advances, and will be given by Dr. William Abraham. Dr. William Abraham is a professor of medicine and chief of division of cardiovascular medicine at the Ohio State University College of Medicine. He also served as the deputy director of the Dorothy M. Davis Heart and Lung Research Institute. He is very well published and has been an active trialist on many aspects of this field. His role has been in the kidney and heart failure, neurohormonal mechanism in heart failure, sleep disorder, breathing in heart failure, and clinical drug and device trials in heart failure and cardiac transplantation. He is a principal investigator in more than 100 multi-center trials of the drug and devices, and will give an update on this emerging topic of cardiac contractility modulation at the intersection of electrophysiology and heart failure. Dr. William Abraham.
Hi, my name is Bill Abraham, professor of medicine at The Ohio State University, and it's a pleasure to participate in this meeting on top 10 topics in clinical cardiology. I'll be discussing cardiac contractility modulation at the intersection of EP and heart failure. First of all, what is cardiac contractility modulation? Well, shown here are CCM signals, which are relatively high voltage, biphasic electrical signals that are applied to the heart during the absolute refractory period of the cardiac cycle. As such, these electrical impulses are non-excitatory, but they perform a number of favorable effects on the heart that result in an improvement in cardiac contractility without any increase in myocardial oxygen consumption or work, thus improving the efficiency of the heart as a pump. CCM is delivered by an implantable pulse generator, much like an implantable cardiac rhythm management device, such as an ICD or a CRD device. In contrast, though, it has a rechargeable battery and thus a very long battery life. There are two right ventricular septal leads that are used for sensing and for CCM signal or impulse delivery. The signals affect the biology of the failing myocardium, specifically genes, proteins, and phosphorylation, in a way that improves cardiac function. As mentioned, an increasing contractility with no increase in myocardial oxygen consumption. As shown on the slide, it's important to note that these biological effects are seen rapidly in the region of signal application, but it has been demonstrated that the biological effects are seen remotely in the left ventricle over time. Mechanistically, CCM improves myocardial gene expression in the feline human heart. The results shown on this slide look at the expression of multiple heart failure-related genes, which improve with cardiac contractility modulation. These findings come from human myocardial samples from a double-blind randomized controlled study employing serial endomyocardial biopsies at baseline and at follow-up to examine changes in gene expression. Importantly, you will see that during the period in which CCM was turned on, there was a favorable effect on those genes which are associated with improved cardiac contractility, particularly those involved with calcium handling, such as SERCA2a, phospholambin, and others. This translates into an improvement in LV structure and function over time. In studies from both humans as well as animals, CCM has been shown to improve ventricular volumes and the left ventricular ejection fraction, as shown on this slide. On the upper figure in this slide, moving from left to right, you can see the important reductions in LV end diastolic and end systolic volume, and the approximate 6%, and this is an absolute percentage point improvement in the LV ejection fraction. Similar changes shown in another study shown on the lower right-hand corner of this slide. And finally, it has been suggested that CCM has a favorable effect on sympathetic activity in heart failure patients. Here you can see suggested mechanisms by which CCM may influence sympathetic activity. For example, CCM increases septal contraction. Mechanoreceptors then may activate vagal afferents. Sympathetic activity decreases, and there's an improvement in overall autonomic balance. Is there an evidence for an anti-adrenergic or sympathetic effect of CCM in heart failure patients? Well, there is, in this study from Schoppe and colleagues, which demonstrates the effect of CCM on sympathetic nervous system activity as measured by muscle sympathetic nerve activity. On the left-hand side of this slide, you can see baseline results for muscle sympathetic nerve activity in the bottom panel of the slide. You can see that there is quite a bit a heightened state of sympathetic nervous system activity in this patient, as is indicative and seen consistently in heart failure patients. Following 3 months of cardiac contractility modulation, there is a reduction in muscle sympathetic nerve activity or nerve bursts associated with CCM therapy. Well, what does all of this translate into from a clinical or patient-oriented standpoint? Well, first of all, prior to the FIX-HF5C or confirmatory study, there were 3 relevant randomized controlled trials that demonstrated the significant impact of CCM on exercise ability and quality of life. These trials included the FIX-CHF4 study, a randomized double-blind trial performed in the European Union, the FIX-HF5 feasibility or pilot study performed in the US, and the FIX-HF5 larger and pivotal randomized controlled trial also performed in the US. These studies demonstrated quite consistently marked improvements in peak VO2 during metabolic exercise testing compatible with a marked improvement in patients' exercise ability and functional status. And in a pre-specified subgroup analysis of the fixed HF5, we saw that the greatest benefits were seen in patients with mildly to moderately reduced LV ejection fractions, ranging from 25% to 45%. And this was the population of patients that we carried forward into the fixed HF5C confirmatory study. Well, first, let me share this observation with you. This data comes from the fixed HF5 study, looking at the difference in change in peak VO2 over 24 weeks of follow-up. And you can see, as highlighted by the yellow shading on this slide, that those patients with LV ejection fractions of at least 25% or greater demonstrated the most marked improvements in peak VO2 with cardiac contractility modulation. So now let's take a look at the confirmatory study, the fixed HF5C study. This is the study that ultimately led to US regulatory approval of cardiac contractility modulation. This was a 160 patient randomized trial performed at 20 US sites and 8 sites in Europe. The target population was heart failure patients with ejection fractions ranging from 25% to 45%. The primary effectiveness endpoint was an improvement in peak VO2. The primary safety endpoint is outlined on this slide. The major secondary efficacy endpoint was quality of life. And it's important to note that this trial was done under the auspices of the US FDA's Breakthrough Devices designation. To make a long story short, the fixed HF5C trial was markedly positive. Here is the primary result of between group difference in peak VO2. You can see that compared to control patients, the CCM patients had on average a 0.84 ml per kilogram per minute improvement in the peak VO2. To put this into some clinical context, exercise training for patients with HFrEF improves peak VO2 on average by about 0.5 ml per kilogram per minute, and cardiac resynchronization therapy improves peak VO2 in patients with wide QRS complexes on average by about 0.8 to 1.0 ml per kilogram per minute. So this finding compares very favorably to other approaches and other device-based therapies for the treatment of heart failure. In addition, in the fixed HF5C trial, CCM significantly improved quality of life and functional status. Let's start first on the left-hand side of this slide with the changes in the quality of life score. Here, using the Minnesota Living with Heart Failure questionnaire, there was an 11-point between group improvement in quality of life seen in CCM patients. Remember, with this particular quality of life instrument, a lower score is a better score. It's associated with an improved quality of life. And this 11-point between group difference also compares very favorably with other well-established heart failure therapies. For example, drug therapies in heart failure improve this quality of life score on average by about 3 to 5 points. And cardiac resynchronization therapy, again, in the CRT indicated population, improves this quality of life score by about 9 or 10 points, showing again how favorably CCM compares with well-established heart failure drug and device therapies. And then, as shown on the right-hand side of this slide, as judged by the clinician, according to the New York Heart Association functional class ranking, more CCM patients improved by at least one New York Heart Association class when compared to the control group in the fixed HF5C analysis. In addition, a pre-specified subgroup analysis of the fixed HF5C trial demonstrated significant improvements in peak VO2, quality of life score, and New York Heart Association class, regardless of ejection fraction. In both HFrEF patients, those with ejection fractions less than 35%, and what we might call the HFmREF, or mid-range or mildly reduced EF patients with ejection fractions ranging from 36 to 45%. There were significant clinical effects in both groups of patients. And finally, CCM may improve outcomes. The data shown on this slide, looking at the combined endpoint of cardiovascular death and heart failure hospitalization, comes from a combined analysis of the FIX-HF5 and FIX-HF5C studies. Here you can see a statistically significant better outcome, a reduction in this composite endpoint in CCM versus control patients. Now, neither of these trials were prospectively designed or adequately powered to look at this endpoint, so this observation should be confirmed in future studies, but it's important to note that there have been published other more recent and mostly observational trials that demonstrate improvements in clinical outcomes with cardiac contractility modulation. So let me summarize what I've said thus far. First, based on the totality of clinical data in New York Heart Association Class 3 heart failure patients with HFrEF and HFmREF, that is with LV ejection fractions ranging from 25 to 45%, CCM improves exercise capacity, quality of life, and functional status. It shows strong trends toward improvement in morbidity and mortality, especially in reduction in heart failure hospitalizations. And it has an acceptable rate of device or procedure-related complications, which is similar to that seen with cardiac resynchronization therapy. These effects are seen in both HFrEF as well as HFmREF patients, and thus CCM is a valuable addition to our armamentarium for the treatment of heart failure, especially in HFmREF, where no effective drug or device therapies exist. Now let me update you on the current regulatory status of cardiac contractility modulation, because this has become a device-based therapy that can be used in your patients across many geographies around the globe. CCM has been CE marked and commercially available in many countries outside of the US for quite some time, and there is an extensive post-market experience with the use of CCM in the European Union. On March 21st, 2019, about a year and a half ago, the FDA approved CCM for use in the United States. The indication is as follows. The Optimizer Smart System, which delivers CCM therapy, is indicated to improve 6-minute whole walk distance, quality of life, and functional status of New York Heart Association Class 3 heart failure patients who remain symptomatic despite guideline-directed medical therapy, who are in normal sinus rhythm, and who are not indicated for CRT, and finally, who have an LV ejection fraction ranging from 25 to 45%. Now let me cover just a few frequently asked questions, and then I'll conclude with an algorithm for the use of cardiac contractility modulation therapy. First of all, who prescribes this therapy? Well, really any clinician who takes care of New York Heart Association Class 3 heart failure patients can refer patients for cardiac contractility modulation. Who implants the device and performs the procedure? Well, here's where we come to that intersection between electrophysiology and heart failure or general cardiology, because it is our electrophysiologists who implant CCM devices, or those skilled in the implantation of cardiac implantable electronic devices. What's next for this therapy? What does the future hold? Well, there is ongoing development of a combined CCM ICD device, and also trials will soon start, which may expand the indication for CCM to other heart failure populations, perhaps those who are less sick or those with even more preserved or higher LV ejection fractions. And then finally, who should really receive this device? Well, I think those who are indicated in the FDA label and where the focus of studies such as the FIX-HF5C study are ideal candidates for this therapy. And that includes heart failure patients with class 3 symptoms, despite optimally tolerated guideline-directed medical therapy who are not candidates for CRT. And finally, let me conclude with this simple algorithm for who should receive this therapy. So those patients just mentioned on the prior slide, heart failure patients with New York Heart Association class 3 symptoms, despite optimally tolerated guideline-directed medical therapies. If that patient has a CRT indication, a wide QRS complex, particularly a class 1 indication, such as a very wide left bundle branch block, that patient should receive a CRT device, either a CRT pacemaker or a CRT defibrillator. If the patient does not have an indication for CRT, then there's an additional question to ask. What's the ejection fraction? If the ejection fraction is less than 35%, that patient should have both a CCM device as well as an ICD device. And if the answer is no to that question, if that patient falls in that LVEF range of 36 to 45%, then that patient is a candidate for a standalone CCM device without a concomitant ICD. I want to thank you very much for your attention.
Colleague and numerous publications, well-designed trials of drugs and devices, and also have received numerous honors by institution and nationally by American Heart Association and also Ellis Island Medal of Honor. With that note, I'll ask Dr. Keeney to talk about update on the mitral and tricuspid, knowing that the aortic has become the usual run-of-the-mill, that what is evolving in this mitral and tricuspid field. Dr. Keeney.
Good morning, everybody. I'll be talking on evolving paradigm of transcatheter mitral and tricuspid valve repair and replacement. I have no conflict of interest in this presentation. So if you see here, untreated severe mitral regurgitation is associated with increased morbidity and mortality. Mitral regurgitation begets mitral regurgitation, and 1-year mortality could be up to 57%. That's because there is increase of LV load, LV dilatation increases mitral regurgitation. Not all patients who require treatment get surgery. If you see here, only half of the patients get surgery even if they're symptomatic, especially when they get older, the treatment is denied. So classification of mitral regurgitation, there are 2 kinds. One of them is primary. The problem is in the mitral valve, which we discuss, anatomic abnormality of the mitral valve, which could be leaflet, subvalvular apparatus, chordae, or muscle. The secondary is because there is an issue with the muscle. So there will be LV dilation, annular dilation, which gives rise to mitral regurgitation. So prognostic determinant of MR depends on the severity, left ventricular function, as well as the symptoms of the patients. So this was 2017 ACC expert consensus in management of mitral regurgitation. Essentially, first you got to know how to make a diagnosis of mitral regurgitation, identification either by primary care or cardiologist. You do a transthoracic echo. You can do further non-invasive modalities to figure out the mitral regurgitation. Then you define whether it's mild, moderate, severe. Then you have to start the treatment. Usually the treatment is heart valve team, which includes cardiologist, imaging expert, interventionalist, a surgeon, and the entire care. So what you need to know is medical therapy. There is surgical treatment, which could be repair, replacement, also AFib ablation if these patients have a AFib, and then transcatheter treatment, which is mitral valve clip I'll be discussing on, and then they need a regular follow-up also. So this is just the various types of mitral regurgitation. Again, based on the type of Carpentier classification, you can then make a diagnosis as well as treatment based on the type. This is another algorithm to say how mild to moderate mitral regurgitation can be diagnosed, who should be referred, when they should be referred, and the treatment they should be getting. So in this algorithm, who should be getting mitral clip is that patients who have symptomatic mitral regurgitation, which is primary, which is degenerated mitral regurgitation, and who have prohibitive surgical risk, they can get mitral clip. But the same thing for secondary, we'll discuss more. The general principle of therapy of MR, if it's primary, could be no medical therapy, and if there is symptoms, they should go for surgery, whether it's repair or replacement. The considered prophylactic repair for a low risk with long-term survival means young patients who have prolapse, have a severe MR, no symptoms, you can consider repair in these cases. But what is important is when you have functional MR, they have to be on medical therapy first, consider also CRT, and then they should be considered either for surgery or percutaneous treatment. How did mitral clip get approved by FDA? The one trial that we need to know was Everest 2, which was a randomized clinical trial, was surgery versus clip. Device group was 1, 2 versus the control group was 1, and you see the follow-up was 30 days up to 5 years. And what did they find? That this device was very safe compared to the control, and effectiveness, we always knew surgery definitely was very effective compared to mitral clip. But if you see here at 12 months, 3 to 4 MR was seen about 18% of the patient on echocardiography compared to only 2% in surgery. But if you go on symptoms, the symptoms of NYHA class 3 was only seen in 1% in the device group compared to surgery. Essentially saying that these patients need to continue on medical therapy even after they get percutaneous treatment. Same freedom from death, MV, and surgery. The landmark analysis showed the crossover happened in the first 6 months. After that, the survival was same whether they got clip or they got surgery. Now coming to a case presentation, this is a 79-year-old female who had cardiomyopathy, multiple comorbidities, ongoing symptoms, on medication, and was very limiting with her activity. So if you see here, severe MR on echo, this is 3D echo showing that there is a combined, there's a prolapse of the anterior leaflet of the mitral, and here is the fluoroscopy, how to do a transeptal. This is the catheter entering into the LA. We had to place 3 clips. This is the final. In the 3D, you can see there is 1 clip, 2 clip, 3 clip. So we are able to actually trace the V wave when we are doing the procedure. So after 1 clip, this is the initial, which is showing a large V wave up to 80, went down to 50 after 1 clip, which went down to close to about 40 when we placed the second clip, and then went down to a mean of about 18 after the third clip. What's important before we, once we place the clip and we are about to release the clip, very important that we need to make sure that there's no gradient in the mitral valve. One thing you do not want to do is take care of the MR and give mitral stenosis. So this is a TVT registry outcome saying the same success rate. This is all comers in the registry, 92% success, in hospital mortality about 2.7%. And this is what happens at 1 year follow-up. And what you see, the mean age of 82 and STS score is about 6.1, means essentially these are very sick patients, elderly patients, and cumulative death as well as rehospitalization. If you see here, FMR usually does slightly worse than DMR. And what what did study show? That when you are treating patients, your mitral regurgitation has to be taken care completely. If you left residual mitral regurgitation, the outcome is poor, survival is poor. Also, concomitant tricuspid regurgitation is also a predictor of poor survival in these patients. 2 trials that were recently published had separate findings. One was, we will discuss both of these trials moving forward. If you see here, NEGM with a different result. One was MITRA-FR study. The design showed that if you see patients, total enrollment, once patients were diagnosed with mitral regurgitation, they were assigned either to medical therapy or to the treatment arm. And once they got the treatment, then patients were continued on medical therapy. So what did it show? The mitral clip success was about 96% or so. And as you see here, the procedural complications were very little. But clinical outcome at 12 months, primary endpoint, death, hospital readmission or MACE, no difference between the 2 groups. This is the same thing at 12 months, all-cause death and unplanned hospitalization, no difference. Co-opt study was done here in America, again, multi-center trial. Patients were randomized 1-to-1 mitral clip plus medical therapy and medical therapy alone. This is how patients were screened and randomized. Very important, if you see here, very strict criteria. Before they were randomized, patients had to be symptomatic. They were on, heart failure, definitely with BNP greater than 300. After treatment, had to be on good medical therapy. And I'll go over that, what it is. And look at the LV function was less than 50, but more than 20. And end systolic dimension had to be less than 70. So this is just the baseline characteristic saying these patients were very sick patients with multiple comorbidities in this group. So medication that were used, very important for general cardiologists to know that they were, most of them were on beta blocker, ACE inhibitor, nitrates, diuretics, all of these medications they were taking. And this is a major change in heart failure medication within 12 months. Means if did they tolerate and did the medication had to be changed, it was about 6 to 7% or so, not a lot. So majority of them tolerated the medication. So what did the clip procedure show? That about 93% of, close to 94% of the patients had their MR reduced to less than 2+, which is essential. Like I showed you in the previous TVT registry, that you had to bring your MR to less than 2+ or even less than 1+. So guess what? Look at the results. That mitral clip definitely had better survival compared to GDMT, as well as this all-cause mortality, decrease in heart failure. This is combined death as well as heart hospitalization, significantly lower in this trial, because it was a well-done trial. And very important, another event that we showed, that these patients who are on heart failure regimen, we know they are waiting for another definitive treatment, which could be waiting for transplant, LVAD. The need for that actually decreased in this group of patients who got a clip. So what did the MR core lab show? That patients with the mitral clip compared to GDMT, look at how the reduction in this patient when they came back at 30 days up to 12 months, was less than 5% or so. That is why these patients did very well. So if you see here, co-op trial result at 2 years and MITRA-FR trial at 1 year, the difference. Why was the difference between the two, MITRA-FR well as co-op? The biggest difference is because the type of patients that were enrolled. If you see here, the co-op trial enrolled patients with MR, but the LV EDP was not LV dimension, and diastolic dimension was not too bad. They did not wait for a LV to be dilated too much. So this is the term that the editorial viewpoint was proportionate versus disproportionate mitral regurgitation. So patients with co-op trial had disproportionate MR, essentially LV and diastolic volume, if you see here, was lower, so the MR was higher. But what happened in MITRA-FR, the volume or LV and diastolic volume was higher, or we say what we call a burnt out LV. So when you reach to a stage of burnt out LV, even if you fix your mitral regurgitation, they do not respond well. This is another ongoing randomized trial which is going on everywhere. So mitral clip wins the FDA approval for secondary MR that has been now approved by FDA, and we've been able to do this procedure. Going to the next one is if they have prosthetic mitral stenosis valve, they have already a prosthetic mitral valve and there's a stenosis, is there a treatment for these patients? This is just to show you of a patient with NYHA class 3 who already had a mitral prosthesis, which you can see here, and there is stenosis of this prosthetic valve. Is there a treatment for this patient? Yes, we can go there and place a TAVR valve in that particular position. If you see here, a TAVR valve is being placed in the mitral position, and this is how it looks, final result. The echo showing that the valve was good. So we can do this kind of valves in certain kind of conditions only, not in all. You cannot do it in patients who have calcific mitral annulus. You can do it in patients who have valve in valve only, maybe valve in ring. So mitral valve repair, look at the landscape. There are several valves that are available. Some of them are in trial, some are first-in-man cases, many of them actually in the development. Two valves actually are in the trial. One is the Medtronic 12 and the Abbott Tendyne. We actually are part of the, now, going back to this valve, if you see here, there are various shapes and sizes because the anatomy of the mitral valve is very complex. So there's no one valve that will fit into that. This is the Intrepid Apollo trial. We are, Mount Sinai is part of it. Actually, it's an apical axis, 35 French sheath, and this is primary, secondary objective, primary endpoint. So enrollment is ongoing right now. It is very slow because of the current situation, but we'll be able to get it going soon. Now, why TMVR is very challenging? Because there could be LV obstruction. There could be perivalvular MR still left. There could be embolization of the valve. And right now it is still apical access. And other thing that you could have is coronary compression or LA injury. So there are a lot of challenges here. The question is, we know CLIP did well. Would co-op trial result affect the TMVR trial design? We need to wait and see. So conclusion, DMR versus FMR, co-op to TMVR is that mitral clip has been approved for prohibitive surgical patients. Very important, prohibitive surgical risk. About 400 cases are being done in the US. That was before the current situation. And it has now been approved for patients with the FMR who already are on guided medical therapy. Very important that they got to be on good medical therapy. They still have symptoms and MR. That's the time we can make sure they can get the clip. So TMVR valve in valve using a TAVR Sapien valve can be done for mitral bioprosthetic valve. For valve in a ring, we are not sure, but you can be considered. And TMVR utilizing complete replacement of mitral MV. So far, mixed result. There are ongoing trials. We just have to wait and see what they show. Moving on to tricuspid valve. If you see here, there is a septal leaflet, anterior leaflet, posterior leaflet. This is a beautiful anatomy showing how complex tricuspid is. Going to the type of tricuspid regurgitation, primary regurgitation. This is the secondary tricuspid regurgitation and what is called as isolated, where only I think there's atrial dilatation giving rise to TR. This is where you see a dilation of the RV giving rise to tricuspid. So functional tricuspid regurgitation, we know that if it is left-sided giving rise to the left-sided pathology giving rise to TR, anterolateral jet, but if it is AFib on top of RV involvement, it gives rise to posterior jet. So clinical outcome, we all know severe TR, worse survival and more cardiac event, especially if they have symptoms. And this is telling us that the lot of patients, about 1.6 million out there, but the surgical treatment is provided to a very minor population. What are the various surgical tricuspid repairs available? Is leaflet cooptation. You have stabilized annulus, and very important, avoid conduction abnormality. Various techniques that has been shown here, which are surgical techniques. So national trend and outcome in isolated tricuspid regurgitation. So over years, the number of tricuspid surgery has gone up, but still the in-hospital mortality is just about 8 to 9% shown in this particular paper. So what did it say? Isolated T-wave surgery is largely performed, although utilization has increased over time. Despite an increase in surgical volume, operative mortality has not changed. So given the increasing prevalence of isolated TB disease in population, research into optimal surgical timing and patient selection is critical, saying that some treatment option has to be provided to this patient. What are the various approaches? Your superior vena cava approach, inferior vena cava approach, transapical, transatrial, and this is what target we have to do. The tricuspid therapy wise, what is out there? Cooptation device, one of the important device I will show is a FOMA device. This is the clip. Now, heterotropic caval valve implant. This was the first treatment that was initially decided to be done for tricuspid cases. And then you have a tricuspid ring annuloplasty or suture annuloplasty. So various devices out there telling there's no one treatment that can be given to patient. When may a transcatheter preferred over surgery? All depends if the tricuspid anatomy is favorable and there has to be a good TE imaging. And RV, if they should not have pacemaker and RV lead is not in between inhibiting the cooptation. These are the various trials that are ongoing for tricuspid regurgitation. So long-term outcome of the one device, FOMA, which I just mentioned initially, what did it show? That very small group of patients, but still at follow-up, if you see here, the severe TR actually went down, 33% decrease. And it's the same thing, vena contracta width, the size of the IVC also decreased at follow-up, saying that there was some promising result here. 1 year outcome of H2H repair, which is the clip that was done for tricuspid, is the same thing at baseline and follow-up. Significant decrease here in the tricuspid regurgitation. If the procedural success was there, you see that was a survival benefit in this patient who got the clip. This is the Triluminate trial, which was a pivotal trial. We were part of it, and right now a randomized trial is going on. This is the same clip that being used even on the mitral side. This is the first Triluminate case that we did here at Mount Sinai. If you see here, severe RV, RA, severe TR, the same thing being shown in 2D echo. Baseline TE, this is the first clip grasping, and we are trying to close the clip here. Compared to majority of the percutaneous procedure that we do that requires fluoroscopy, both the mitral clip as well as tricuspid clip does require a lot of imaging. Now, this patient already had a previous mitral clip. So you see the mitral clip is here. Patient also had a ASD occluder, and this is telling you the anatomy. The anterior leaflet, septal leaflet, posterior leaflet, and how we are trying to grasp as we are going. This is the second clip that we are trying to place. And this is the second clip, which is already in there. You see here. So post deployment of, you see here, anterior septal, and this is the anterior posterior. So this is the mitral clip and 2 tricuspid clip that were successfully placed in this patient. So significant decrease in the tricuspid regurgitation. If you see, this is the pre-implant and this is the post-implant decrease in the tricuspid regurgitation after placement of the 2 tricuspid clips. This is mild to moderate TR when they come back at 30 days. So this is a randomized trial, which again Mount Sinai is part of. Patients have to be on therapy, and they should cannot have pulmonary artery pressures higher than 70. And when they are screened well, we have been placing the patient. What are the other devices that are available out there? This is the Edwards Pascal transcatheter valve repair system. It is another one that looks like the clip. It's a little wider. This is also being used both for mitral as well as for the tricuspid side. The various coaptation devices, coaptation essentially trying to, take care of the valve. FOMA repair system, which we already discussed, then H2H repair using mitral system, and the Pascal, which I just showed you. This is just to work on the clip for the coaptation. This is suture annuloplasty, and here ring annuloplasty, another kind of a device that is available. This is a cable implant, which was the first one that was started, but right now not being used. This is a cardioband system. Again, trying to put like a for the annular, decrease the annular size. So proposed algorithm, if it's primary or secondary, if there's prolapse, consider clip. If it's a rheumatic cause of tricuspid, consider a TTVR. And lead induced means you can consider either a coaptation problem, or you can place a valve. Then secondary, again, various devices are out there. So it's not one particular treatment. Patient needs to be evaluated and then considered. Bioprosthetic tricuspid regurgitation, stenosis and regurgitation. Are we able to take care of this patient? Yes, this is a case who already has a bioprosthetic tricuspid valve, valve, and then had restenosis. So this is the previous valve, and we were able to place the sapien valve on the tricuspid area. This is how the final tricuspid implant looks. No TR with a mean gradient of only 5 post-procedure. This is the same patient algorithm for tricuspid intervention. If they're if they're on medical therapy, if they're still refractory to symptoms, based on what the pathology is, then we can consider what treatment can be given, whether it is H2H repair or various other devices that I just discussed. So conclusion for TTVR take-home message is untreated severe TR carries a poor prognosis. Tricuspid repair with the remodeling annuloplasty is the current gold standard in surgery. Transcatheter repair is at its infancy. As I have shown you so many devices trying to say it's not one treatment that can be done. In leaflet coaptation or annular, decreasing the annular size is the way to go. Heart team approachment and early evaluation and maximize opportunity to offer entire spectrum of therapy, which includes medical, surgical, or transcatheter should be considered. Now, all these things that I've discussed, you can also watch many of these live cases on ccclivecases.org, which has been going on for over 11 years and structural for over 7 years. So if you see here, total page views per month are almost close to 30,000 or so. We are on the YouTube channel where you can watch these various live cases and understand how it what involves in referring these cases, as well as the treatment wise. We are on the Facebook, we are also on the Twitter, Instagram, and we have created several apps. These are mostly for interventional cardiology, but still anybody out there can learn based on these apps also. These are the cath lab apps with the several downloads that are mentioned here. And if you see here, they are free to download. You can either go to Google Play or App Store and download these apps. Thank you for your attention.
Fantastic. Very relevant. All the data where we are and what will be in the future. Thank you, Dr. Keeney, for excellent presentation. And that leads to the last presentation of today. That is the top 10 advances of interventional cardiology in the recent time. Good morning, and now we come to the last topic of our top 10 topics in clinical cardiology 2020, a virtual conference. And I hope it has been very beneficial and educational to all of you. My goal in next 25 minutes and so will be to give you top 10 recent advances in coronary intervention. And as you know that I always start my presentation by giving a tribute to the father of angioplasty, which is Andreas Grundtvig, whose dream was the catheter-based percutaneous treatment of vascular disease in alert and awake patients. And of course, I added with utmost safety. The top 10 advances which I will be presenting, they come from many articles, many studies, many papers which are presented or published. The purpose of including those articles are that they are revolutionary, have a significant observation, widespread acceptance, and changes our clinical practice. Let's start with the first, Taylor PCI. It is a genotype-guided antiplatelet therapy choice. As you are all aware, that clopidogrel is the inactive metabolite, inactive agent, which is activated in the liver by various cytochrome 450, the most prominent being CYP2C19, and makes it the active metabolite. And what has shown that in many patients, many people, there is a deficiency of CYP2C19, and that occurs this minor allele frequency up to even 35% in the Asians. So what will happen in those patients? Your clopidogrel will not be effective. And what studies have shown that the patients who have deficiency of CYP2C19, they have a higher cardiovascular event. These were the multiple studies which were presented about 15, 20 years ago. With that note, the FDA recommended, give a black box warning that those who have carriers of 2 loss of function allele, that is what those patients should be given another agent instead of clopidogrel that is more stronger, ticagrelor or prasugrel. To see whether genotype testing, which is available now at a point of care in the cath lab, results can be available within 0.5 to 1 hour. It's a saliva test and gives you whether patient is a carrier or not. And if it's a carrier, then you give prasugrel or ticagrelor. If it's not a carrier, then you continue clopidogrel versus usual care. And this is a small study of ADAPT PCI of 500 patients showed that using genotype guided therapy did not make any difference. But we needed to do a multi-center large randomized trial, and that was the Taylor PCI, which was the genotype guided selection of oral P2Y12. And this was a large trial of 5,300 patients, half in the genotype guided therapy, half in the conventional therapy. And what they did is, in the genotype guided therapy, patients who were CYP2C19 loss of function, those received, the majority received the ticagrelor, and some of course still received clopidogrel. In the other group, which is conventional, the testing was done later, and those who were also the CYP2C19 loss of function carrier, they were given usual treatment. And what did we find? Overall, the genotype guided therapy had a trend towards lower death, MI, and stroke and stent thrombosis, but had a higher bleeding rate. So it still was a trend only, and other individual endpoints are shown here. So overall, it shows that genotype guided therapy did not make a difference. And that was the basically conclusion, and has a very nice editorial that we are not ready to do a routine genotyping to guide our antiplatelet therapy. The second is the defined PCI and Forza imaging trials of PCI. As you know, that in order to improve the outcomes of PCI, many adjunct, whether it's a physiological guided or the anatomical guided with the IVUS and OCT, are being done to improve our outcome. So defined PCI was the blinded physiological assessment of residual ischemia after successful angiographic PCI. Why? What is the background? Because studies have shown that even after successful PCI, some of the patients still have FFR of less than 0.8. And you can see that if you want to optimize, you can of course post dilate, put additional stent if you know in these cases, which happens in 10 to 20% of patients. Also, it was shown that these patients are associated with those who have higher residual FFR, they're associated with higher event rate. So clearly there is a correlation of a higher residual FF, means a significant FFR less than 0.84, or otherwise as 0.80 have a higher event rate. So question is, how often do we encounter routinely? And this was the main objective of the defined PCI trial, that rate of residual ischemia defined as IFR of less than 0.8. after operator assisted successful PCI. And of course, they found that after the point, all patients had an IFR of 0.89, had an intervention, and then had IFR pullback at the end. Operators were not, they were blinded. They were not told what were the results were. And what we found in this study, that pre-PCI IFR was 0.69, became, as you can see here, 0.93 post. But many patients, if you take the cutoff of 0.89, some of them actually FFR was less than 0.89. So clearly it appeared that about 24% of patients, there was a residual ischemia still based on the IFR. And majority of those were the focal. When we did a pullback, it was a focal, whether it's an unexpanded stent or dissection or residual lesion, while in 18% was diffuse. So majority of them had focal. So you can make a point that if you can take care of that focal residual ischemia, you'll improve the outcome. And that has led to this major trial called Define GPS, which is the IFR guided therapy versus standard of care. And we'll know the results in next few years. In the same field, also angiographic versus FFR guided from the SCAR registry showed that in large number of patients, by using FFR guided PCI, decreased mortality over 10 years. So 22.7 versus 30.2 seems to be that clearly the FFR should be incorporated in the routine armamentarium. And it happens because by FFR will identify the vulnerable plaque, which is only 50, 60 or 70%, and also will reduce overall ischemia and decrease the stent use. Then question comes, is FFR better or OCT better? So we have a trial called Forja, that FFR assessment, then FFR guided PCI or OCT assessment. They have criteria for OCT optimization. And what they found basically, the major adverse event or angina status did not change, was identical between two, whether it's FFR guided PCI or OCT guided PCI. Yet, few other things which happen, the procedural cost, length of stay, and total cost of the procedure seems to be lower in the FFR guided PCI. So you can make it a point that FFR should be the routine in our interventional armamentarium. The iLumen 4 will give the final answer whether OCT guided PCI in the complex high risk clinical or lesion characteristics versus angio guided PCI in 2,500 patients with primary endpoint of 1 year target vessel failure will know in next 2 years. Then comes the THEMIS and THEMIS PCI trial of ticagrelor in diabetic patients. So we have tried many other secondary agents in addition to aspirin, like clopidogrel. So basically, knowing that ticagrelor has shown to decrease event in patients with acute coronary syndrome, MI, post PCI. So goal was that what if patients who are diabetes and stable CAD without a history of prior MI or stroke or had a PCI more than 1 year ago, whether adding ticagrelor will be beneficial. And that was the basis of the THEMIS trial. 20,000 patients, half were assigned to ticagrelor, other half to placebo, all received baby aspirin. And basically you see here, primary endpoint was 0.7 lower in ticagrelor group. And of course, the individual endpoints are here with the stent thrombosis 0.3 lower, but at the cost of significantly higher bleeding, including the intracranial hemorrhage. So you can say that, yes, you have little benefit in terms of ischemic endpoint, but you have a higher bleeding rate. So therefore, conclusion was that you have a trade-off. So routinely, I would not recommend giving a ticagrelor to the diabetic patient with a stable CAD. Now, within that group, there was a sub-study, was the THEMIS PCI, that what if the patients of those 20,000 who had a PCI, what happened to selectively to those pre-specified group? So half, 57.8% of the PCI group had ticagrelor, and other half got just the placebo, and the individual type of strategy as shown below. And basically, the observation was kind of similar what was the main THEMIS study. That is, by giving ticagrelor, those who had history of PCI did have a lower ischemic event, but much higher. Remember, difference was 0.7. Now the difference is 1.3, significantly lower stroke rate, lower MI rate, significant. While patients who did not have history of PCI, there was no effectiveness of ticagrelor. Now, at the same time, if you go to the bleeding, I know we were worried about the bleeding in the main THEMIS trial. Here also bleeding occurred, but no longer the intracranial hemorrhage or fatal bleeding. So therefore, you can say that selected patient with the the diabetes who had prior PCI, who had no indication to continue ticagrelor, may benefit as long as you are concerned. Just take care of the bleeding, which can occur still in some percent of these patients. And this actually put it together. Patients history of PCI, the net clinical benefit favors ticagrelor along with baby aspirin, and no history of PCI was no different. Question always comes, what if you would have taken out the aspirin from this armamentarium? Maybe would have been lower bleeding, and I'll come to that point a little later. So we also know now we have the anti-reversal agent for the ticagrelor, and you will be soon hearing about it, and can rapidly neutralize the effect of ticagrelor. So going to the next level is the Augustus trial of NOAC, basically warfarin, which we know has been done of various trials combining where there is need for antithrombotic therapy, Bush trial, Pioneer AFib PCI, Redual PCI, all of them have looked into various combinations and found the best combination was the vitamin K antagonist or NOAC plus one antiplatelet therapy. And that basically had led to the second part from the agent which the Augustus trial to see whether apixaban is non-inferior to vitamin K antagonist in patients who have AFib and ACS or PCI, and also whether you can take away the aspirin. Is there any additional advantage of aspirin? So twofold question. So here, all patients with the AFib who needed a PCI or acute coronary syndrome, given apixaban 5 mg twice a day, patient with special subgroup got 2.5 twice a day, or vitamin K antagonist, and 2x2 factorial design got aspirin or placebo in each group. And what did we find? Once you compare apixaban with vitamin K antagonist, superior in terms of the lower bleeding. And if you take aspirin, turns out to be that aspirin has no advantage. Only the bleeding was significantly lower, of course, once you don't give aspirin. But now question is, what if you combine both? And as you see, of the 4 combination, the best combination was apixaban with placebo is the lowest bleeding, and vitamin K plus aspirin has the highest bleeding. So that we understood. So vitamin K antagonist, when we use the antiplatelet therapy, we usually give clopidogrel, don't use aspirin. But overall, it seems to be that you can drop off aspirin even in these patients with acute coronary syndrome and patients who had PCI. And this was true even you have medical management of ACS or PCI or elective PCI. Though seems to be that we are going away from aspirin, and then come back to this point a little later. Then the Safari STEMI trial of radial versus femoral access. I know numerous trials have been done to evaluate the femoral versus radial, and it has become class 1 indication, having a lower mortality in patients with STEMI or acute coronary syndrome radial access because of lower bleeding and of course the lower mortality. Matrix trial was one of them, and this was the latest recently conducted trial from Canada called Safari, and basically they took all the expert centers for both femoral as well as radial and took patients with STEMI and randomized radial versus femoral. And as you can see here in this trial of one of the large trial of 2,200 patients, there was primary outcome of mortality was no different at 1 month, and secondary outcome of reinfarction, stroke, or death was no different. Also, other endpoints of stent thrombosis or bleeding, which was one of the plus points for the radial, we were not observed in this trial. Why? Because they're very expert operators. So this actually puts it together that yes, even femoral is okay in STEMI patients, and of course suggests that what require is the good vascular access, whether femoral or radial, and in this trial, radial did not add to any better outcomes. And this actually puts into the various meta-analysis which have been published in this field. So next is the Excel trial, PCI versus CABG of unprotected left main 5-year results. As you all recall, the 3-year data were presented of a patient with a syntax score less than 32 with unprotected left main, science versus CABG, and 3-year data were presented 2 years ago and now presented 5 years. Overall, death, stroke, and MI at 5 years was not different. As you can see here, 22 versus 19.2. But very interesting observation that first month, actually PCI is better, had a lower event rate compared to CABG. From 1 month to 1 year, they were both identical. There was no difference. But after 1 year to 5 years, clearly advantage of the CABG. So clearly, you can look into that when we have a patient to encounter, what is the life span of that patient, then you can make the decision on these patients. Individual endpoints are here. Overall, the death clearly was higher in the PCI group versus cabbage, and of course, the stroke was non-statistically numerically lower. Rest are shown, except that higher revascularization, which we knew will happen in the PCI group. Also, if you take the graft occlusion or stent thrombosis, definitely was much lower in the PCI group. So this actually, these are the old recommendation. Class 1 is a hard team discussion, whether United States versus Europe. I think all these guidelines will change after the Excel trial 5-year results. I expect that some of the low risk may become class 1 indication for the unprotected left main PCI also. So clearly, I also want to just highlight a lot of controversy on this field. Also, at the same time, there is a lot of meta-analysis have been published, taking all the randomized trial, comparing PCI versus cabbage for death, MI, stroke, basically no difference overall, and unplanned revascularization definitely is against PCI. In the same field, that the DK crush, what should be the technique? Do you use the routine provisional stenting versus 2-stent approach with the DK crush technique? Earlier data were presented for 1 year, then 2 years, then 3 years. It shows that DK crush technique is superior to provisional stenting as shown here, and along with the lower stent thrombosis and the TLR and so. So it seems to be, once you plan the bifurcation left main stenting, DK crush is superior to conventional. Or only thing is that there was no comparison with the mini crush, which many people use. In the same field, also there is data that volume drives outcome for unprotected left main PCI. And this is a study basically showing that low volume, intermediate, and high volume operator, 6, 24, or 38, they have a half decrease the mortality from 4.1 to 2.1 in the experienced high volume operator. So clearly, that is where you should be looking for. And the additional the data came is in terms of imaging. This is from the British Cardiovascular Interventional Society, that imaging, which is done in about the 12 to 13% of patients. But overall, event rate is significantly lower in the imaging guided PCI. So this is, we are talking about mortality, 8.9 1 year versus 12.9. So imaging guided for unprotected left main is the right thing to do. And that is what soon, in my opinion, will become class 1 recommendation. Right now, it's still is a 2A. So then moving on is the complete trial of STEMI PCI strategy. We were aware in last 8 years, the concept of culprit PCI has gone to the complete revascularization based on the PREMI, CVI culprit, and permeability trial, and all of them in a different combination, whether you do same time or do a stage PCI or FFR guided PCI, all led to the one common notion that complete revascularization in STEMI patient is beneficial compared to culprit vessel PCI. Now that has led our recommendation from class 3 go down to 2B for STEMI for the multi-vessel PCI. So this complete trial was the largest of trial of its type, and evaluate the strategy that whether complete is revascularization better versus culprit, and also when you do a complete revascularization, should be done at the same hospital admission, or you can do it few weeks later as a stage intervention. Again, it's a 4,000 patient trial, and the patient, half of them in the complete revascularization had a PCI done within same hospital admission within 2 to 3 days, or we did after 3 weeks, and so. So what is the results? Basically, the complete revascularization had the 2.7% mortality versus 3.7. So 1% decline reduction in mortality. Number needed to treat is 37. Very, very relevant observation. And if you take the individual endpoints are shown here, significant reduction in MI, and of course, repeat revascularization. So seems to be complete revascularization is a way to go in patient with STEMI. Now, whether you do initial hospitalization or you do it after initial hospitalization, as you can see here, it did not make a difference. Complete revascularization, event rate remains same, 2.7, 2.7, 3 or 3.1. Even you put into a ischemia-driven revascularization, but seems to be that the complete revascularization done at time, initial hospitalization, or in a stage fashion within 1 month is appropriate. Now that actually will change the guideline. I am hoping in our updated guideline soon. Now this is a little different than cardiogenic shock. Cardiogenic shock, the shock trial, basically culprit shock showed that doing a multi-vessel PCI in cardiogenic shock, which was our concept 20 years ago or 10 years ago, has completely changed after the culprit shock. That the only the culprit PCI was have a lower mortality at 30 days compared to the full or multi-vessel PCI. And of course, that the renal replacement therapy was also the same. So it seems to be that all the concept of the cardiogenic shock, you do only culprit vessel PCI. And this actually it will lead to the 1-year outcome, as you can see here, in favor of the culprit vessel PCI in cardiogenic shock. And I think this already have changed from the 2A to class 3, that cardiogenic shock, you do only culprit vessel PCI. Going to the next one is the ISAR React 5 trial, or prasugrel or ticagrelor, and that basically lead to of course, we know that in Triton Timmy 38, the prasugrel was better than clopidogrel. In Plato, the ticagrelor was better than clopidogrel, but at the expense of higher bleeding. Both studies showed higher bleeding. Now, what about comparing these two agents? This is a small trial, Prague 18, of 1,200 patients, randomized to prasugrel or ticagrelor, and found no difference. So we did have some background that amongst these two agents, there is no difference. Now, this was a major trial from Germany, ISAR React 5, comparing ticagrelor to the prasugrel to patients with acute coronary syndrome, and majority of them were non-STEMI and STEMI, so true high-risk patients, and of course some have unstable angina, and basically found that the ticagrelor was inferior to prasugrel as a primary endpoint of death, MI, stroke, and stent thrombosis, as you can see here. Clearly, the lower event rate which is height of the blue bar, prasugrel, and there was no difference in bleeding. So clearly, prasugrel was superior to ticagrelor and no difference in bleeding. I can tell you, I have been a big believer of the prasugrel. I have been using quite a bit, and now since the trial, a lot of switch has taken place, and this puts it together in terms of the clinical endpoints at 1 year, death, MI, and stroke in favor of prasugrel over ticagrelor, and no difference in bleeding. Now, also, the idea is go away from more aggressive, more potent P2Y12 agent, particularly the patients who are at high risk. This is a popular ACE trial, elderly patients more than 70 years with non-STEMI, and they compared clopidogrel versus ticagrelor and found that clopidogrel was superior to ticagrelor in terms of lower bleeding without any difference in the ischemic endpoint. So you can recommend that now. So coming back to one of the major trial of 2019 and 20 will be twilight trial of aspirin discontinuation. Now, what it is, we all know that in the beginning, after the PCI, we really need a strong agent, DAP. After 1 year, probably we don't. 3 to 6 months, it probably is or 6 to 12 months, we may decide whether continue or not. But most of the trials which are done, they have abbreviated the duration of PTY12 to 3 to 30 months. Many trials were done to answer that question. But what if we still know that bleeding occurs? So what if that we continue the stronger P2Y12, particularly in the twilight trial, will be ticagrelor, and take away the aspirin. So whole issue was that maybe aspirin causing no benefit, rather harm. And we know that initial trial of large patients of 16,000 patients, global leader trial, did show that by removing aspirin, you did have a trend towards a better outcome of death, MI, or death, and without any difference in terms of stent thrombosis or so. Seems to, and of course, the bleeding was no different. So seems to be that dropping aspirin after 1 month in these patients was completely fine. Then there was a Glassy study that was the adjudicated clinical outcome at 2-year follow-up from the same global trial, and message was same, basically that dropping aspirin would lead to a significant reduction in death, MI, stroke, or urgent TBR. And of course, no difference in bleeding. So seems to be that aspirin stoppage is fine. Then there were 2 other trials were done for the PCI. One was a smart choice where 77% were clopidogrel, 23% were prasugrel or ticagrelor, and in these patients, the 3 months of DAP, and after that, the aspirin was stopped. So basically, what we found that monotherapy after 3 months versus DAP, clearly in terms of primary endpoint was no difference, but you have a lower bleeding. Same, the similar concept was the stop DAP2, in which the aspirin was stopped after 1 month. And this is the second agent is clopidogrel, not the more potent P2Y12, and saw the similar message. That is, that overall you had no difference in ischemic event, rather you have a significantly lower bleeding. So seems to be that aspirin is a culprit and may not be needed whether you are using clopidogrel or in the global freedom trial using the ticagrelor. That lead to the major trial by Dr. Roxana Maran. The trial was conceptually designed at Mount Sinai, implemented globally with the multiple centers and the multiple countries. And the trial hypothesis was that patients undergoing PCI who are at high risk for ischemic or hemorrhagic complication and who have completed a 3-month course of DAPT with ticagrelor plus aspirin, continued treatment with ticagrelor monotherapy would be superior to ticagrelor plus aspirin with respect to clinically relevant bleeding and would not lead to any ischemic harm. The concept basically was that taking away aspirin after 3 months, will it decrease the bleeding? That one. Secondly, will it increase any ischemic event? And that was our primary and secondary endpoint of the trial. Trial done conducted very rigorously, and it was the first of the placebo-controlled trial which done in this field, and basically saw that BARC 2, 3, or 5 bleeding was significantly lower in the ticagrelor monotherapy group. This is 3 months, everybody got aspirin and ticagrelor. After 3 months, no aspirin, and significantly lower. And these are the individual endpoints of the bleeding. And now if you go to the ischemic endpoint, basically death, MI, and stroke, you did not find any difference. As you can see here, remain identical. So same, whether it's a stable syndrome, acute coronary syndrome benefit. There was another trial called TAIKO trial from Japan, within patient with acute coronary syndrome getting PCI. They also stopped the aspirin after 3 months and found that overall 12 months primary outcome in favor of stopping the aspirin after 3 months. And of course, benefit occurred after 3 months when the aspirin was dropped. And in terms of lower bleeding, while the MACI remains the same, rather trend towards the ticagrelor monotherapy. So seems to be the field that changed, and aspirin can be dropped between 1 to 3 months after PCI. That leads to our major trial and top 10 advance of the recent interventional cardiology, the ischemia trial of invasive versus conservative treatment. And this is, background is, we know that a stable coronary artery disease, PCI versus medical therapy was identical as we knew in the COURAGE trial. Although within COURAGE, there was a nuclear sub-study that showed that PCI do a better job of reducing ischemia, more than 5%, and reduction of 5% ischemia drives the lower event rate. So that was the basic concept. And that multiple trials of PCI versus optimal medical therapy of risk of mortality and risk of MI have shown no difference. So that led to the ischemia trial, that what if we take a moderate to severe ischemic patient and try medical therapy or do the invasive approach. All these patients had a blinded CTA to see if there is no coronary artery disease will be excluded or left main, which selectively should go for revascularization or excluded. So clearly, these were the patients with the invasive strategy, with optimal medical therapy and cath, conservative strategy, optimal medical therapy, and cath only for optimal medical therapy failure. These all patients had to be stable. Unstable patients were not enrolled. Very rigorous trial. Eligibility criteria, exclusion criteria took 9 years to complete this trial of 5,000 plus patients, and 2588 randomized to invasive and 2591 were randomized to conservative strategy. And of course, majority of these patients have a moderate to severe ischemia. And rest of the risk factor modification were very aggressive and very appropriate, which you'll see in the most of the trial patients. And also, whether patients were assigned. So patients who assigned invasive treatment, 96% got it. In conservative, 28% had a crossover and required revascularization in 23% and 80% revascularization in the invasive group. 20% did not require revascularization in the invasive group because they were insignificant disease or they have the extensive disease unsuitable for any mode of revascularization. 74% got PCI, 26% got cabbage, and basically the outcome was conservative versus invasive strategy at 5 years. Although numerically lower, about 2.2%, but p-value was 0.34. And of course, you can see that at 6 months, identical. After that little separation, I expect that maybe a 10-year or 7 or 8 year will have a bigger separation as shown here. So now if you take a cardiovascular death or MI, the similar story, which was shown for the overall endpoint, And for MI alone, there was a little interesting observation that in the invasive strategy, higher MI early time because of the procedural MI, but after 2 years, as you can see, the curve just started separating in favor of lower MI in the invasive group. And if you make it see here, that spontaneous MI was much lower in the invasive group. And that's a very remarkable observation that stable CAD patient, PCI reduced the spontaneous MI. And so conclusion basically was that in patients with the ischemic patient, whether you try invasive strategy or conservative is fine. Primary endpoints were no different. But yes, the invasive strategy reduced the incidence of spontaneous MI compared to conservative strategy. And it is the first trial which showed that. And of course, the long-term benefit of this may will require another 5 years to show. There was also quality of life. Patients particularly filled up the quality of life questionnaire, which is done basically the SAQ score. That patients, particularly on the invasive group, anytime you go on the right side, as you can see here, the people who have invasive therapy, and particularly, as you can see, the ischemic at 3 months, 12 months, or 36 months, more you are coming towards the zero. That means they're having a lesser ischemia. So that is what basically saw in patients with the monthly angina score. Now, if you have no angina, then there was no difference in invasive approach. So basically, the more you are going away from the median, that basically that better was the quality of life score. So seems to be that the relieving angina invasive strategy was superior. And of course, a lot of media publicity on this field, and of where this field will go is still need to be seen. So basically, from interventional cardiologist perspective, I would say that we need to decide based on what patient needs. It is appropriate even in ischemic patient to maximize their therapy and do PCI as a once the symptoms are not controlled. But at the same time, if patient wants to relieve angina, ischemic directed revascularization was superior to medical therapy. And so this leads to our all top 10 advances of interventional cardiology. If I had to put it together, some of the message that what did we learn in these trials, the radial PCI or STEMI, ticagrelor in patients with diabetes and genome testing in PCI, there was no benefit. And then FFR guided PCI, clopidogrel in the elderly, invasive RX in ischemic heart disease, one benefit. Conservative RX in ischemic heart disease, PCI for left main, multiple STEMI, NOAC alone, definite plus, and real plus was prasugrel in ACS and aspirin, drop within 1 to 3 months post PCI and continue ticagrelor to become better interventionists. And of course, these are our recent data, the highest volume with a great safety, lower 30-day readmission at Sinai. Also, just want to tell you trend in the America, overall, there has been a almost 40-50% decline in revascularization, whether PCI or CABG. I think this is the power of medical therapy which has been shown. We actually continue to teach globally in 138 countries, over 12,000 people per month with the CCC live cases, showing the complex case. And I really thank my cath lab team to get us where we are, provide the best care to a large number of patients here. And thank you very much. Okay, so this is we went a little overboard, but all the messages have been communicated of the top 10 advances yesterday and today, lot of questions. So I think some of the questions have been sent to individual faculty. There are more coming. We'll continue to answer. Maybe we can start with the first, our speaker, Dr. Greg Stone. Some questions have been directed to you. If you can read them with who sent it, and just a brief bullet answers for all the questions, because there are a lot of questions today. Right?
Sure, I'll try to remember. I deleted the email that had the questions on it, but I think I remember. So one question, a basic question was, how can you have a substantial plaque burden if it's only a 30% angiographic stenosis? And that's a really important basic concept for people to understand. The angiogram only shows the lumen, okay? And we know that when you start developing atherosclerosis, what actually happens is that plaque gets deposited in the media and the artery grows outward. That's called the so-called Glagol phenomenon. So you can accumulate a lot of plaque in the vessel because the artery keeps getting bigger and bigger and bigger. And it's not until you get to about a 40% cross-sectional area narrowing where the plaque starts extruding into the lumen. And if you have diffuse disease in addition, then the whole lumen can appear equally narrowed, so you can't tell how much plaque there is. So the plaque burden refers to that cross-sectional narrowing, and you can have a huge amount of plaque in the artery and a substantial narrowing in a cross-section of an artery where the lumen on the angiogram appears to be only mildly diseased or even normal. Another question was what do you do with an asymptomatic person who had a calcium score of 1,000 and is being treated with a statin and has an LDL of 50 and is absolutely asymptomatic, has no ischemia on a treadmill, and exercises to 12.9 meds. And I think the answer is today, you're doing everything you can. You want to aggressively manage that patient's risk factors, but the patient is asymptomatic, has normal exercise function, his LDL is quite low. We don't yet have data to say you should add a PCSK9 inhibitor and drive him under 30. Some people do believe that. If he's not on a maximal dose of statin, you might increase the maximal statin to the maximal dose. But with an LDL of 50, I think you're doing pretty well. Make sure that all the other cardiovascular risk factors are strongly optimized. We don't yet have data to say you should do an invasive interrogation to look for vulnerable plaque and then potentially either treat it with a PCSK9 inhibitor or with a stent. But we'll be presenting some data toward that end in TCT in about 3 days with 2 new studies, one of which is randomized, called Prospect Absorb, about the prophylactic treatment of vulnerable plaque. And I can't remember the third question, so I think I'll stop with answering those first 2.
Yeah, so well, we'll come back to more questions. There are more coming. Now, Roxana.
Hi, I didn't get the questions either. So if you have them, Dr. Sharma, you can read them and I'm happy to answer them.
Okay. So now one question was, what criteria do you use to qualify patient with a low versus high bleeding risk? And is there any publication?
Yeah, I mean, I think that's it's a great question. And there are obviously multiple risk scores that are used for evaluating bleeding and ischemic risk. But I think the best possible way to define a patient at high bleeding risk is using the Academic Research Consortium ARC bleeding HBR definitions for defining an HBR patient. And that as long as you get one major of those criteria or 2 of the minor criteria, you get in. And those are listed in, elderly, CKD, prior stroke, malignancy, there's several, prior bleeding, all of those things are all listed as a very, very good reference that you can use. It's the best, I would believe it's the best possible way of really qualifying that, certainly in clinical trials, and that's what we're going forward with. But the other thing is that none of this takes away your clinical judgment of what you believe is a high bleeding risk. And sometimes that, to me, is even more important. A patient on an oral anticoagulant, an elderly, frail woman, for example, who's small in size and is at risk for fall. I mean, those are the kinds of things that are really intuitive senses of high bleeding risk. And certainly anyone who's had a prior bleed fits into that category.
Now, other question is that if you are giving with the NOAC, the clopidogrel, should you be testing it? You do need to worry about people who will be non-responder immediately after PCI?
I think that's a really good question. If you're going to drop aspirin really, really quickly, and you just did a left main PCI in a high bleeding risk patient and with atrial fibrillation on NOACs, and you want to send them home and stop the aspirin, you better check it. I believe that you should be checking that. And I think in a very high ischemic score, ischemic burden on the patients with multiple stenting, left main, et cetera, I would say in those patients, you probably want to definitely test them and give them about 30 days of aspirin on top of it. Now, the default therapy, as I said, is really dropping the aspirin. And this 2020 consensus document, which is in press at the moment, will let us know for how long. If you look across the trials, it's somewhere between 0 to 14 days from all of the trials when aspirin was dropped in the randomization arms of Pioneer and Trust, Augustus, and Redual. So we are giving up to about 7 days or so for those patients with when you're going to drop the aspirin.
Yeah, so I think that's an important point. I think based on complexity, many of us in the cath lab, as Dr. Mehran pointed out, give it for 1 month, 1 week or so, and many of the cases can be dropped, and I actually routinely drop it. But yes, we don't have a clear-cut guideline, but yes, studies are till 1 month. So key is that can you do less than 1 month will be the major issue all the time. So now actually come back to Greg again. That's a very important question, that patients with ACS, with acute STEMI, and which patient should you be testing for the lipid-rich vulnerable plaque based on the risk factors? And if you find a plaque into other vessel, which you already mentioned, what you do with terms of vulnerability in the non-ischemic vessel, I mean non-culprit vessel. Culprit you already took care with the stent. Now you found based on your prospect data, how do you guide it till the data which will come with a prospect 2?
Sure. Well, again, we'll be presenting the late-breaking trial in 3 days, so I hope everybody will be able to join us for the virtual TCT Connect. We'll have a lot of new, very insightful information about that question, where we did 900 patients with STEMI and non-STEMI, and then did 3-vessel interrogation with NIRS IVUS. And we also randomized a subset of those patients to either treatment with a scaffold versus medical therapy alone. So it will be, I think, very interesting in relation to this question. But what we know going into this trial is that in patients with either STEMI or non-STEMI, there will be about 4 or 5 additional substantial plaques that you don't see in the coronary tree, that usually have an average diameter stenosis of 20 to 30% on the angiogram, sometimes even less. But they'll be very bulky plaques by intravascular imaging, and they're often lipid-rich. And we know that about 1 out of 3 of those will be a thin cap fibroatheroma, the ones that place the patients at particular risk. So the real question is now, should we look for those? If we find them, how much extra is the risk? Right now, we can only find them through 3-vessel imaging. What we showed in Prospect 1 was using virtual histology. What we'll hope to be able to demonstrate with you in a few days is whether or not near-infrared spectroscopy is as good or better. And if you do find such vulnerable plaques, what should you do about them? Should you intensify your lipid-lowering therapy or anti-inflammatory therapy? Should you consider focal plaque passivation with stenting? And we'll be getting at those questions by showing you the results of the randomized prospect absorb data. So today, where we are is that we don't yet have an indication to do 3-vessel intravascular imaging. We know patients with STEMI are going to have a lot of other plaques that you can't see. They've got diffuse atherosclerosis, and they'll have a lot of vulnerable plaques. So my general recommendation is, even knowing that, even not demonstrating that, you certainly have to very powerfully control their risk factors and drive their LDLs very low. Currently, the recommendations are less than 70. I would drive them down to less than 50. And if it was me or a family member, I'd want to see them as close to 30 as possible. So I'd have a very low threshold for a PCSK9 inhibitor if a statin is not doing it, or statin and ezetimibe. And again, finally, the potential to be able to transform the field to say we should be looking for these and consider plaque passivation, because we know these vulnerable plaques can have a 10 to 20% adverse event rate within 3 or 4 years. We should be able to do better with stenting. These are non-flow limiting lesions. There's no indication to treat them today, but we should be able to reduce that rate with stenting. But again, we'll show you the results of Prospect Absorb in a few days. That's a pilot trial. Then we'll need if that's sufficiently convincing, then we need a large-scale randomized trial to really show the safety and effectiveness of that approach.
So actually, towards that is another very important question, that do you recommend in a FFR negative patient with some chest pain, plaque burden more than 70, or lumen cross-sectional area of less than 4, would you stent this patient?
Well, today,
FFR is negative.
Like I said, today we can't recommend that. Today we can only really recommend for ischemia, considering stenting patients with a positive FFR or IFR, demonstrated. We've got to also think about the wisdom of that and really reserve that for symptomatic patients. Now, that's in stable ischemic heart disease. What about in acute coronary syndromes? Well, we've learned from the complete trial that after a STEMI, any severe lesion, that is either angiographically severe or positive FFR, then you want to, quote, prophylactically treat that because you can reduce the myocardial infarction rate. But whether we should be doing that in less severe lesions and that are FFR negative, today the answer is no. We don't have data to do that, but we hope to be able to generate randomized trial data in the future to support that indication.
Okay, great. Now, I think Dr. Bill Abraham, you got your questions. A lot of interesting, some of them actually you answered by your presentation, but I think if you can just answer there, because there are many questions for you.
Yeah, absolutely. Let me go ahead and bring those back up. Okay. So some of these relate to CCM and ICD therapies. One is what about the combination of CCM and ICD therapies, and certainly that is an attractive combination. Currently CCM comes as a standalone device in patients who also have an indication for an ICD, either a primary or secondary indication for an ICD. They'll have to have two devices currently, a standalone ICD device and a standalone CCM device, but as mentioned, there is under development a combined ICD CCM device, and that will really be an additional breakthrough for our HFrEF population. I think one of the reasons why we see the penetration of primary prevention ICDs at being something less than desirable in the indicated population is that while primary prevention ICDs reduce the risk of mortality, they don't treat heart failure per se. They don't improve the way patients feel. They don't improve patients' exercise ability. They don't improve other endpoints that are really meaningful to patients. So adding a therapeutic benefit, heart failure therapeutic benefit on top of an ICD makes great sense. And I think that's coming. Now let's take a look. Some additional questions that I have here. What about the effects of CCM on LV remodeling or reverse remodeling? There is evidence both from animal models as well as in human studies that demonstrate reductions in left ventricular volumes, both systolic and diastolic volumes, associated with an improvement in ejection fraction. That improvement in ejection fraction is similar to what we see with the use of CRT in patients with wide QRS complexes. And speaking of CRT, a number of questions were raised about CCM and CRT. First of all, let me remind the audience that CRT is indicated for about 20% of our reduced LV ejection fraction heart failure population. So for patients with ejection fractions of 35% or less, the strongest indications for CRT, those associated with a very wide QRS complex and a left bundle branch block, might capture about 20% of the overall heart failure population. The majority of heart failure patients have either a narrow QRS, where we know that CRT does not work and in fact might be dangerous, or they have a non-left bundle branch block morphology of their wide QRS complex. So CCM may address a much larger population of patients than addressable by CRT. But one of the questions that was asked by the audience was, can you use the two together? And the answer is that theoretically, one could. Currently, there is inadequate data upon which to make a recommendation about the concomitant use of CRT and CCM therapy. But it certainly is an attractive thought, particularly in those patients who are CRT non-responders or perhaps have improved but improved inadequately with CRT alone. So more studies to come. I think we'll have more data on the concomitant use of CCM and CRT therapies coming in the future. Let's see if there's anything I missed here. I think that covers the highlights. One question was, how did this concept originate? I honestly don't know. There have been, there's been some thinking related to what happens to contractility after blocked premature contractions, and whether or not that potentiates contractility for the next beat. But, I really can't give you an answer about how the thought originated. But now, after many years of study, the concept seems to be well proved.
Great. I think we'll come back with some more questions. So let me answer two questions which were dedicated, directed to Dr. David Rich after the wonderful talk. That how will the experience change? Plan for a potential resurgence. What would the system do differently? So Dr. Rich comment is, thanks for the kind words. For a future surge, the logistical plan is largely identical, albeit easier to manage with more adequate reserve of PPE and other supplies, promising trends for therapeutics and respiratory equipment. As a health system, we learn to share best practices such as access to research trial in all our hospitals and seamless transportation among hospitals to optimize patient care. We'll continue to improve those processes. Second one was that did your hospital staff contract COVID or die during the time? So he said, sadly, a small number of Mount Sinai healthcare workers succumbed to COVID-19 among our 42,000 system employees. We mourn their loss and rededicate ourselves to fighting the pandemic. Yet, with alternative medical care for those who become ill and consistent social masking and social distancing practices until vaccines are widely available, we have kept many safe and will continue to do so. Basically is that, yes, it could happen, but we need to be maintain all the precautions. With that note, Dr. Keeney, you got some questions?
Yeah, I have my questions. One of the question was ongoing trials for mitral clip repair in primary severe MR with poor surgical risk or due to other comorbidities. Yes, there are several ongoing trials. There is a clip, I mentioned the clip that was approved. There is another, which I showed also, which was the Pascal clip, which is ongoing. And I think in the anatomy of the mitral valve, I did mention how complex the mitral valve is. So there is no one treatment for the mitral regurgitation. So whether it is primary or secondary, so the various devices need to be considered depending on the pathophysiology of the MR, where the MR is arising from, and then we can make a decision what is the best treatment for the patient, clip or repair. And then comes for a tricuspid clip. Would carcinoid tricuspid disease qualify for a triluminate trial? All depends, whether the type of regurgitation. When we do the echocardiogram, TE will determine, how significant it is. And yes, just because they have carcinoid would not be excluded. But of course, there are other, if carcinoid is involving other body parts, will be difficult, maybe based on what the trial enrollment criteria is. Then there is another question saying, how does a Cardiolon mitral annuloplasty compare to mitral clip? No comparison has been done. I know there was a small study showing that it was done for secondary MR patients with heart failure, essentially decreasing the annulus. Yes, it did decrease the mitral regurgitation, but head-to-head comparison has not been done in this patient. And then the other question was, what can be done for severe TR if there is a pacemaker wire? Again, the issue will be the same. Which part of the the valve the pacemaker wire is? If it is in the center, will be a major issue to clip it. So a couple of cases, what you have done is then you have to remove the the wire first. They can remove the wire and then put a leadless pacemaker if the patient is pacer dependent. If the wire is on the side closer to the commissure, then of course we can place a clip with the wire in place. And the last question was that about a broadcast case that we had done. It was a live case. The person mentioned that we did a tower. It was actually, it's a mixed question. The case we did was mitral case where a prosthetic valve, the case exactly that I showed, where you can place a sapien valve in patients with a degenerated prosthetic mitral valve. And during the live case, we did have some issue that the valve got stuck. patient did go for surgery. Those are the questions.
So I think there are more questions which we'll ask individual. One question was very relevant, was directed towards me. That is that knowing the genotyping testing is not widely available and no solid data, should we just do a platelet function assay on the equimetrics? And so I think that's what we're doing at present. So in cases where there is a borderline, we know that even in complex PCI, non-acute coronary syndrome, if you need to give, you can give ticagrelor or prasugrel. But if there is a question about bleeding and you still have to give clopidogrel, let's say left main. I had a case actually last week. Left main patient has a prior TIA, has a bleeding. So in that particular case, you want to make sure that your clopidogrel is working, although we know that platelet function assay testing guided therapy did not make any difference. There were 5 randomized trials which have been done in this field. But case by case basis on those high risk patients, we still routinely do on those cases if we are not changing to a more potent P2Y12. So only thing what we are doing more and more is take away the aspirin. Where the bleeding issue is there, take away the aspirin and just continue either any of the monotherapy, which I think looking like a data, all 3 of them seems to be quite well. But clearly patients with a super high risk complexity, and you cannot use the newer P2Y12 or more potent P2Y12 or ticagrelor or prasugrel, that case definitely should try to use clopidogrel. So question is, what can you do then? Well, then you may decide maybe still give the more, ticagrelor, prasugrel, or make a clopidogrel twice a day, which we know for some of the trials in the past have shown. So with that, Roxana, you have some more questions for you?
No, I think from what I'm seeing, we answered pretty much everything, Dr. Sharma.
Okay, now one question was, knowing that now more and more patients are coming on the ticagrelor alone, and now they need a non-cardiac surgery or even cardiac surgery. The surgeons are very much afraid, and now you're giving patients ticagrelor 1 year, 2 year, based on various trials. So how would you manage those, cases? And third question was, another question for you was, if patient is aspirin allergy, how are you managing those patients as a unitherapy or so?
Well, I think we've done this before in our aspirin allergic patients, which it's not that it's quite a rare thing. And in aspirin allergic patients, we've brought them in and we've done desensitization, because aspirin in the peri-procedural arena is quite important. And we like to kind of at least give those patients aspirin. If not, we've used glycoprotein 2B3A inhibition and other things in those patients in the past, but it really is not a very large body of evidence to talk about. Regarding what do you do in the patients who are on ticagrelor monotherapy for a prolonged period of time, the most data we have is from TICA monotherapy is really from 2 trials, Twilight and Tycho. Twilight and Tycho both, in fact, Twilight a little bit longer than Tycho. Tycho only had ticagrelor monotherapy for 9 months. Twilight had it for 12 months. We do not have prolonged use of data on prolonged use beyond a year of use of ticagrelor monotherapy. And we did not see any issue. We're going to be presenting the data on both the sites of bleeding, the reasons why, on the patients who had to go and have surgery and were on ticagrelor monotherapy versus not, and what those bleeding complications were. But we all know that if it's early after a stent, stopping both dual antiplatelet therapies before surgery could have a negative implication for adverse cardiac outcomes, especially in the first week and up to a month after a stent implantation. At this year's TCT, we're going to get data on the Cobra stent, where there is only 2 weeks of dual antiplatelet therapy on these very, very high-risk patients with a Cobra stent, which is a non-drug-eluting, but it does have a formulation of a coating, a coating on that stent is a polysine coating, which is supposed to be thromboresistant. Only 2 weeks of dual antiplatelet therapies in patients on an oral anticoagulant. We're going to look at that, and we're going to be presenting that, and I think there's going to be some trials with that particular stent in patients undergoing surgery and what to do around the time of surgery. we still are very unclear about what to do around the time of surgery. And as you know, even for non-cardiac surgery, the data is very, very sparse. And what to do around that with, let's say, even use of cangrelor in the perioperative period. The data that we have on the bridge trial, it was for cardiac surgery, not non-cardiac surgery. So there's a lot more that we're looking to explore and working to design studies in this arena to look at this prospectively. At the moment, what we're doing in patients who are on potent agents and need to have urgent procedures, we stop the potent agent, we keep them on the aspirin, and we let them go on for their surgery. That is what we're doing. When it's spine surgery and very, very difficult intracranial surgery, that's when we stop both anticoagulant, antiplatelet regimens and watch those patients very, very closely. And in a very rare case, when it's early after stenting, we would do some bridging with the use of cangrelor.
Great. Now, Greg, there is another good question for you. Oh, sorry. Yeah.
I wanted to respond to that last question as well, because it gets even more, I mean, Roxana's points were excellent, but it gets even more complicated. And I think you really have to consider what the ischemic setting was. Were the stents put in because of a recent STEMI, a non-STEMI, or stable CAD? And we know that the stent thrombosis rate goes up almost exponentially, with STEMI being the highest, then non-STEMI, then stable CAD, with about 75% of all the events still occurring within 30 days. So in stable CAD in particular, we really have no evidence that you need anything more potent than clopidogrel. And in fact, we tried to run a 2,000 patient randomized trial called Trigger PCI, which was going to be prasugrel versus clopidogrel in clopidogrel hypo-responsive patients. And we had no events, essentially no events in patients who were on aspirin and hypo-responsive clopidogrel. Okay, so you saw in the Excel trial, where there was a lot of stenting done, including left main, how low the stent thrombosis rate is with contemporary stents. So I think in what's really fascinating from Twilight is the results are indisputable. But what would they have been like with prasugrel instead of ticagrelor, and what would they have been like with clopidogrel instead of ticagrelor? And should there be a difference in the way we look at stable and acute coronary syndromes? So I personally was surprised in Twilight there were so many patients on ticagrelor monotherapy with stable ischemic heart disease. I would almost never recommend it, to be honest.
Well, so really good point, Greg. And those are exactly the questions. And I actually disagree with Dr. Sharma, if I can ever do that, because he's put so much of his confidence into the ISAR React 5 study, and I really have a lot of issues with that trial, given that there were many, many issues. But what Greg brings out are important questions. Can monotherapy be very similarly replicated with prasugrel? Is there any role in a stable coronary disease for a more potent agent, if ever, especially with complex PCI, which you have done? And is it better than having the patient on aspirin and clopidogrel? What if you put a patient like that with the stable coronary disease instead of aspirin and clopidogrel on just prasugrel or ticagrelor monotherapy, where you really have no issue of non-responsiveness? And if it's a complex, really multi-vessel stents and et cetera, could you really gain the benefit of a more potent agent and reduction of events and similar bleeding? Those are really important questions, and believe me, Greg, we're designing trials like that. So all of your questions are absolutely perfect for the kind of setting the stage for the kind of trials that we absolutely must do in a large scale with really meaningful answers for these important questions.
Beautiful. So let's come back to, I think, unless there is any other question comes, the last question is actually for Greg. And this is a lot of interest on this vulnerable plaque. So question is, patient has non-obstructive CAD. You did a testing, high plaque burden of more than 70%. Statins already everybody has spoken about statin, LDL is 65. Would you put this patient on ticagrelor or colchicine?
So again, really interesting question. I think Ticagrelor, probably not. We don't have evidence that, again, the antithrombotic benefits from ticagrelor would overcome the increased bleeding. And you saw, I think, in both the Pegasus trial and in Themis that the bleeding can actually be worse than the ischemia benefit. So I think we have to be very careful in whom we use these agents in absent clinical trial data. The colchicine is a very interesting question. And of course, we have a few positive randomized trials now about colchicine, but they're in very specific settings, very soon after STEMI in particular. So I would consider colchicine in a patient with a high CRP who had a recent acute coronary syndrome, but I would almost consider that independent of what my invasive testing was. So we're now at the point in vulnerable plaque where we can identify these plaques. We know they put the patients at increased risk. We know they occur in the patient with systemic inflammation, but it's kind of like driving, to focal cavity formation. And now the question is, do you prophylactically treat the cavities versus not? And we have to answer that in well-designed randomized trials.
Well, with that note, we come to the, unless anybody has issues. Yeah, sure.
I just wanted to, I think your point is very well taken. And I fully agree. But let me just add about the Themis trial and the Pegasus study. Now that and this is a question back to you, Greg, now that you've seen what ticagrelor monotherapy is able to do and the platelet substudy showing no real further evidence of further platelet inhibition in presence of ticagrelor for aspirin, would you, if you were to design Pegasus and Themis PCI, would you do a ticagrelor monotherapy arm as opposed to having a additional aspirin on top of TICA? And maybe those results would have been a lot different and that it wouldn't be just a null effect.
Very
Absolutely.
important.
Without any question. In fact, I don't know that I would have the ticagrelor plus aspirin arm after Twilight. I would probably just have the ticagrelor monotherapy arm.
Okay. With that note, I really thank our great faculty for a very insightful presentation. And that exactly, I would say, from my point of view, I'm sure with Anu and Jagat will feel the same, that the main the aim of this top 10 cardiology topic has been achieved with a great interest by the audience. And we thank our audience, which was again but 270 plus for this 10th annual top 10 virtual. I don't know whether it's a good actually, but hopefully we'll be in person that 12th next year. And you'll receive an email from the CME after the conclusion of the course for your CME certificate. And the course will be archived on the coming weeks on ccslivecases.org top 10 topics. More important is that there are the two requests about the slides of the presentation. So we'll ask the speakers yesterday and today, there are PowerPoint or PDF slides which will be also made available, because we know from the video lectures you cannot make the slides, but we want you to make the slides of presentation. Then please visit the virtual exhibit hall featuring the booths of our conference sponsor. You'll be able to view important product information as well as chat to some of the reps in real time via the chat and contact buttons. Thank you again and see you next year.
The world is in the midst of a pandemic, and we are on the front lines. Yet cardiovascular disease is still the #1 killer worldwide and can't be ignored. Welcome to Top 10 Topics in Clinical Cardiology 2020. While COVID-19 has challenged us to take our conference online, course directors Dr. Samin Sharma, Dr. Jagat Narula, and Dr. Anna Porna Kinney have created a packed and compelling program. Over the next 2 days, you'll be exposed to new and emerging approaches in the diagnosis, management, and treatment of heart disease, including COVID-19, opinions of clinical and academic experts, and ways to improve overall care and prognosis. Following our 2 days together, attendees will comprehend the COVID-19 disease process and outcomes, learn to assess CAD risk factors and imaging, acknowledge recent transcatheter valve therapies, recognize the issues pertaining to antithrombotics post-DES, incorporate the latest advances within interventional cardiology. Attendees who are present for both days will receive CME credit, In addition, the full program will be accessible online post-conference on our website, www.ccclivecases.org, and YouTube channel CCC Live Cases. Thank you for joining us. There is nothing quite like the study of cardiovascular disease to remind us to strive towards an active, healthy lifestyle. And remember, wear a mask, wash your hands, practice social distancing, stay safe, and enjoy the conference.